housekeeping things while we're waiting for Jeannie. Just as a reminder, if you wouldn't mind keeping your line on mute, and then as well use the raised hand feature or the chat function. You should be able to chat everyone. If you can't, please let me know. And when you're speaking, if you can just remind to say your organization that you're speaking from. Let's see, let's see if Jeannie Jeannie's not quite here yet, so we'll just kind of let's go to the next slide just as we'll just do kind of some of the housekeeping business while we're waiting for Jeannie. This is just another reminder about your Zoom panel. So you've got the mute, you've got the raise hand function. Next slide. As I'm just, oh, there comes Jeannie. If I stall long enough, Jeannie, our chair, will show up. Next, here's our agenda. We're going to cover just a quick EPSBT check-in. Then we'll have Ariel with the HERC update. We'll do a break. We have our learning collaborator for oral health integration. And then we'll have an afternoon session where we'll do breakout rooms for transformation quality strategy and exhibit I, frequently asked question. Next slide. Oh, I forgot to introduce myself, sorry. Lisa Bowie, Quality Improvement Director, she, her, hers. And Dr. Dawn Montner is out today. So you have myself and Meg Carey. So if you have any questions for any OHA staff, Meg and myself are here. News and announcements. So I wanted to cover a couple different items. So there is and I think I sent it by email, but the history of racism in U.S. healthcare grand round. This is a collaboration from a couple different partners. The American Medical Association, the ACGME, so basically graduate, the grand, what is it? What does GME stand for? You all know. It's blanking.
Graduate.
My mind.
Durable medical equipment.
No, not durable medical equipment, not DME, GME.
Graduate medical education.
That's it.
American College of Graduate Medical Education.
You know, the people in med school, OHSU. National Center for Interprofessional Practice and Education and a Respect for Ability. This I was informed through Rise for Health, but they're doing a grand round series. So if you click the grand rounds word, there's a hyperlink to the whole series. The first kickoff one was a history of racism in U.S. healthcare. It's a really great series. That first kickoff was phenomenal. 1.5 CME credits. It is actually recorded, so you can go and click that link and listen to the actual grand rounds itself. Do recommend that as well. And you can sign up for the second one, which is about leadership in healthcare and racism. So look for the series if you like. Please share it with the providers. QHOC appointments. Ann Kaiser, if you have not received the Outlook appointments, and I know a few of you already have said, hey, this person's changed to my organization, this person hasn't received it, then you can email directly to Ann Kaiser. Her email is there. And then some updates about what's happening in the QPI sessions, the quality performance improvement sessions, which happen here on the QHOC series from 1 to 3. In March, we'll be doing March Mental Health Access Statewide PIP peer learning. So the behavioral health directors at the CCOs and the quality directors will be doing a breakout discussions discussing the strategy and barriers for that statewide PIP. So that will be happening next month. And then, as you have been hearing in the past, where the HERC had migrated their email address, yes, the dreaded email migration has happened to my email. So I have now moved over my email. Well, I haven't. The state has moved my email to the new domain. So At some point, the whatever old one will not probably forward. So you probably need to all pay attention to the new extension or domain extension email. So my new email address is listed below. So it's the @oha.org and .gov. Obviously, if you send me the other stuff, it will be forwarded for some time, but at some point, I'm sure they're gonna, kick it out. So I wanted to make sure you had that. Some other announcements I wanted to let you know is Jennifer Bowen, who's been supporting this QHOC meeting, is going to be transitioning away from supporting this meeting, and Ann Kaiser, who supports a number of CCO meetings. Some of you might be familiar with her. She supports Dave Inbody. She also supports the CCO Ops Collaborative. She'll be starting to support this QHOC meeting. So again, we'll have some consistency across several CCO meetings. So she'll be also supporting QHOC here going forward. That's why you'll be sending her the emails as far as, hey, I didn't get this QHOC meeting announcement, or I didn't get this QHOC material. So you'll start seeing Ann's name. Any questions? Ann, I think you wanted to, did you have a ditty? You wanted to say something or introduce?
No, Ann, it looks like you're still muted.
You might need to do *6 if you're having a mute issue. No, can't hear you. Yep, and here's the deal. Her and Zoom are not friends today. So we will figure out Ann and Zoom. Dave, Inbody uses Teams, so we're going to have to figure out the Zoom with Ann. I do want to thank Jennifer for supporting QHOC this whole time. Thank you, Jennifer. We will continue to transition with Jennifer and Ann, so we will work that out. And thank you, Jennifer, for continuing to support us, especially in this meeting and as you have been doing that. So thank you so much. Any questions or otherwise before we move in the agenda? Jeannie, any other news announcements, or Meg?
Not for me.
None from me either. None from Dawn on behalf of her.
Great. Then let's go to the next slide. Okay, I'm just going to quickly go over, actually, I'm just going to show you, as we did in the last January meeting, we have provided some of the notes that you had from your breakout room. So as we are trying to do from what we heard in the quote retreat from December, is we did some breakout rooms and then provide what you all shared during those breakout rooms. The next few slides are some of that information from your breakout room. So this is just kind of the notes from those themes. Next few slides are really that. So go through those slides. What I'll do is work with Dawn Montner when she comes back and the EPSDT team on any of some of those next steps. Really, some of the next steps are what are other states doing, and some of the other questions were, who do we contact? And I put some of the information that was shared in the January meeting just really on the slide deck. So you have that also in these slides as well. So Jennifer, if you could actually skip ahead, I think like 3 slides. I don't know how many it was. Just keep going. I'll tell you when to stop. So it's really just documenting your notes from the actual breakout rooms. And here we go. I think I can hand it over to maybe Liz or Jessica. Is that one of y'all here? Both of you?
Thanks, Lisa. Actually, the entire team is here. Laura, Liz, and I. So thank you for inviting us back. Happy to be here. I'm Jessica Ickes. I am the EPSDT Children's Policy Analyst in the Medicaid Policy Unit. Next slide. So what have we been working on since implementation? We have been doing quite a few provider education sessions, and we did a large policy overview in January. In this month, we did a prior authorization and billing webinar. And then coming up this week, we will be doing behavioral health and behavioral rehabilitation providers training. All of the webinars are recorded, and our slides are in English and Spanish on our website. The slides have not been put on the website for this week's presentation yet, and those will be forthcoming. Some of the other presentations we have done upon request are allied therapists, school-based health center coordinators, and providers. We'll be doing another presentation for them as well. The Oregon Pediatric Nutrition Practice Group, Oregon Council of Child and Adolescent Psychiatry, and the Oregon Academy of Family Physicians and Oregon Pediatric Society Conference will be forthcoming as well. Next slide. Some of the other work groups we've been working with and making sure to work with our community and partners through this implementation process: the System of Care Advisory Council, Children's Services Advisory Group, and the State Advisory Council on Special Education, and the State Interagency Coordinating Council for Children. Let's see here, Oregon Health Authority, member-facing state agencies that we've been working with. Within the Oregon Health Authority and the Oregon Department of Education and Department of Early Learning and Care, Oregon Department of Health Services. We've also begun working with Oregon Youth Authority as well. Next slide, please. So what we are seeing since implementation as of 1/1/2023 for open card or fee-for-service, denied claims are flagged for manual review until MMIS is updated. We hope that update will be completed by the end of March, is the latest date we have. All submitting providers have been contacted at least once for follow-up, and we have denied 61 claims. The information regarding why those claims are being denied is also provided here. It's a variety of different reasons, and we aren't seeing that they're coming from like one provider. As noted here, we are working with 28 different providers as to these denial reasons. Next slide. So this is what we are seeing from the calendar year of 2022 that have reached the Medical Management Review Committee since the implementation of Statement of Intent 4 and the individual review process for medical necessity and medical appropriateness. So this is looking at a year of those reviews and what we have been working through with the Medical Management Committee. Next slide. And again, here is our email address. If people have questions, and please do, we've been getting some great questions throughout this, and we have been researching our answers and working with other subject matter experts who, if we need to research those questions further before answering. So appreciate patience. Sometimes it does take a little bit of time, but we have learned a lot and are continually updating our information through those questions as well. So thank you.
And this is Liz Stewart. I'm the project manager for EPSDT. And I would probably just also flag for folks, based on a lot of those questions that we are getting in, We are currently working on an FAQ for folks. So that'll be kind of supplementary to all of the guidance that we've issued. We're still working on that, but hoping to get it out soon. So just wanted to let folks know that that is in the pipeline as well. And we are happy to take any questions now. Or of course, you can always submit to this email address. And as Jessica said, all the questions we've been getting are really fantastic, and I think demonstrate everyone's commitment to trying to do this well and really figure it out. So we really appreciate that.
How is it going? Anything new? And I know Dawn would love to have been here for this conversation, but she just is not able to. So she really just wanted to provide a time for you all just to hear from the EPSDT team, and then just field anything new in the last month that may have come up. And again, it doesn't mean that something has to come up, but if there is anything from the CCO teams that you all wanted to share, so that the EPSDT team is aware of anything new in the last month. And if not, then we'll just again let the implementation continue to play out, and then as things surface, we just wanted to make sure we had that space.
Hey, Lisa, this is Jeannie. We're discussing this in COMED as well, and we're kind of working around the questions that we've brought up. I think there were some questions about DME and how DME is, if it doesn't have a certain number called the PDAC number, then it's not considered DME, and how these requests are going through each CCO. And maybe, I don't know how they're dealt with on the fee-for-service side, but we talked a little bit about that this morning as an area that we're just continuing to evaluate for medical necessity. And if certain DME is being requested, but it's not actually considered DME, then just it's all requiring medical necessity review. So I don't think it makes any difference, but it is an added workflow, I think, for folks. And if anybody else from our discussion wants to bring anything else up, I think please feel free. But I think that's it's creating some discussion for us and workflow that we're working on in each CCO.
Okay. And I think we kind of talked about that slightly, didn't we, Jenny, with Dawn during our agenda setting call, so she's kind of aware of that as well. So it sounds similar in nature. So I think she's brought that back to the team. And then I in those previous slides, one of the discussions that we had in the chair call, but also one of the follow-up action items that we're tracking is the prior authorization process and those workflow conversations, and really bring it back after a quarter, after a few months of time, and looking at honestly that process after y'all have had a little bit more honestly time of seeing what the process looks like within your CCOs and honestly within fee-for-service, and looking at what are those prior authorization processes and appeals, et cetera, and bringing it into this group. That was one of the suggestions in the breakout rooms in January. So we'll continue to talk about that within your chairs. And just as a reminder, Laura Matola, Jeannie, Doug, and Laura McKean are your chairs, and we'll figure out how to bring the EPSDT workflow process, grievance, appeals, PA process back into this meeting, probably in the morning session, not just in the afternoon session, and in some kind of way to do that lessons. So the previous slide as a next step. We haven't figured out how we're going to do it, but we said bring it back in a quarter.
Yeah, and I think Lisa, the CCOs are doing some of their own analysis as well on the claim side and looking at anything that was denied and why, and going and making sure that those are appropriate, had medical necessity review and so forth. So and agreed that looking after maybe not just one quarter, but 2 quarters at data within their own CCO and then bringing back some best practices was also agreed upon.
Exactly. And then how we share that. And so we will keep tabs on that particular issue. Any other EPSDT things for the team before we move into the HERC update? Thank you, team, for coming and giving where we are in the fee-for-service OHA land. Thank you for fielding the questions for Dawn. And Dawn, I'm sure will want to hear from y'all. And as the fee-for-service team wrestles with its own implementation in this space, like the CCO. So much appreciated.
Thank you.
Ariel, you have the floor, and Jennifer can advance for you when you're ready.
Great, thanks. I'm Ariel Smits. I'm the Medical Director of the Health Evidence Review Commission, for those of you who don't know me. And I'm going to give you your monthly HERC update. Next slide, please. No new COVID codes. I think this is the second time since 2020. Yay. Next slide. We have a new group that we have put together, our Cancer Genetics Work Group. This group has a CCO medical director, a clinical geneticist who works with cancer patients, and a couple of oncologists joined us. And we've kind of been hashing out cancer genetic testing. For those of you who aren't familiar with that term, these are the tests done on the cancer tissue to see what genes or what mutations the cancer has, which helps you determine which would be the best treatments, especially as we get much more specific with very honed in medications for specific mutations, rather than kind of treating something as a breast cancer. It's treated as a specific mutation cancer. As part of this, the group met in January, and we kind of hashed out a new guideline. They're meeting again this Wednesday. It's a public meeting. I'm sorry, this is not a public meeting. This is a work group. This will be brought, though, to our public meeting in March if anyone has any inputs. We have drafted a new cancer genetic testing guideline that's going to be hopefully kind of hashed out and finalized at our meeting this week. We are going to make, at least the current proposal is to get rid of our biomarkers guideline, make all of the biomarker testing diagnostic, and then have this new guideline kind of guiding when we expect you to cover things and not. Essentially, it's covering tests that are going to have a clinical impact, either letting you know a drug that might be helpful or rule out drugs that wouldn't be helpful with that particular mutation, or whether someone might be eligible for a clinical trial, or a few other indications. And I know we've heard from medical directors about code stacking, where you get the code for a panel of genes as well as the individual genes. And so we're going to try and put some wording in saying that you can't do that. Anyway, so stay tuned. That will be discussed at our March meeting, as long as the work group is happy with their product. And hopefully, if everything goes well, that will be implemented in October. Next slide, please. So the Value-Based Benefits Subcommittee met in January. We approved the HCPCS codes as pretty much I presented them to you all at the January meeting. We updated several things. We updated the cochlear implant guidelines. We tried to bring them sort of up to standard for CMS and the otolaryngology guidelines in terms of There's some wording changes. Instead of an absolute threshold for hearing for small children, it kind of gets a little squishier, where if they have a little bit less of an absolute loss, but they're not, they're really behind in language, that would be another indication. Specifically, we did not change the indication for unilateral deafness, and that will actually be coming back in March for further discussion. And I don't know if any of you all are getting some requests for that, but it was a recently FDA approved indication. But currently our guideline states that we don't cover unilateral implantation. We updated our urinary incontinence surgery guideline with the help of a gynecologic urologist, just to kind of update and make things a little bit more consistent with current practice terminology. We talked quite a bit about our smoking cessation prior to elective surgery guideline. There's the one sort of generic guideline that we have that says that prior to elective surgery, you need to have objective evidence of smoking cessation. The commission is really leaning toward making that less rigid, either making it a statement of intent, or rather than needing objective testing, just basically saying that we offered cessation therapy. But that has not been decided. That's going to be discussed again at March. And I know that's probably of a lot of interest to all of you. So please stay tuned for that. What we did do at the January meeting is we have 4 additional guidelines that had 6-month cessation requirements. And those had 2 objective tests required. For example, prior to spinal fusion, you have to have 2 objective tests and have not smoked for 6 months. We heard from the CCOs that that was a little bit onerous trying to get both of the tests. So we reduced it to you need 1 objective test, but you still need that 6-month cessation. And that's because these are surgeries that really just don't work if you smoke. So those 4 specific guidelines were updated with just that requirement for 1 objective test. And then you'll hear a lot more, hopefully soon, about what their decision is about smoking cessation prior to just general elective surgery. We also reviewed our current organ transplant coverage. If any of you have had much experience with our organ transplant things, they're incredibly out of date. The rules that OHA has about organ transplants are really, really out of date. So the commission approved a few coding changes just to kind of clean up things for organ transplant. And then there's a new kind of a general guideline, has general criteria that a patient, for example, can't have other organs that are failing besides the one that's being transplanted. They have to have their psychiatric illness well enough controlled to be able to comply with follow-up requirements. They can't have active infections that are not controlled. But you can have an HIV infection if it is well controlled. And then that basically for the different organs, it's more or less you need to have, failure of that organ. And for 2 organs, you have to qualify for each organ individually. OHA is working really hard right now to try to change their rules, which we realize are absolutely completely out of date. And they're doing that in as expedited a way as they can. Next slide, please. A couple of other things we did in January, we added coverage for IUDs for endometrial cancer. This isn't standard of care, but it is an acceptable alternative to women who, for example, can't undergo surgery or radiation. We added coverage for prurigo nodularis, which is a rare, very itchy, very disruptive condition, and that will go in our inflammatory skin disease guideline. We clarified that we do cover a 12-month dispensing of contraceptions. And then we did a increase, we modified our urine drug screening guideline. We were informed that currently our coverage is limited to the test that does 1 to 7 drug classes. We were told that in some circumstances there is a need for 18 to 15 drug classes, particularly if you're looking for fentanyl. So we broadened our coverage just to that extra 8 to 15. We still have no coverage for the greater than 15 drug classes. So just a minor change. And then we also looked at Afirma which is a genetic test for thyroid biopsies, as well as the 4K score biomarker for prostate cancer, and continued no coverage. Of note, when we were talking about our biomarkers guideline and all of that, anything that's still in guideline note 173 as non-covered because of lack of evidence, it calls out that those are still non-covered, and that would be where those two tests will be documented. Next slide, please. Our next meeting is March 9th. It's a virtual meeting. It is public. You and anyone that you know would be interested in any of our topics are welcome to attend. We are going to be talking again, as I mentioned, the cancer genetic testing guideline and changes. The smoking cessation and elective surgery guideline will be discussed. We are looking globally at our coverage of single-sided deafness. We currently only cover this for people up to the age of 21, and only for specific things like BAHA and CROS, which are two different types of hearing amplification devices. We are looking in general about adding, or should we add coverage for things like cochlear implants for children and adults? Currently, the recommendation is against that because of lack of evidence that it's significantly effective. And we also looked at expanding some of our coverage of single-sided deafness into adults, which would be more the BAHA CROS. And I believe the recommendation is to continue to not cover because it's not needed for growth, development, schooling, et cetera, and doesn't have that much of an impact on health. We are going to look at vagus nerve stimulators for treatment-resistant depression. The recommendation is to continue non-coverage. We are modifying our biliary colic guideline. This is really to kind of clarify a lot of things. You have to have only a single imaging that shows a gallstone, but you still need to have 2 or more documented clinical encounters that have some consistency with actually having a gallstone. That's our major revision that we're doing. And that's because there was some confusion that we, with the 2 or more incidents that also required imaging. We are looking at trigger finger and trigger thumb. We currently have coverage only for pediatric trigger thumb because we've been hearing that this is pretty disabling and can really affect use of hands, which are extremely important. We are proposing adding coverage with certain criteria and working with some hand surgeons to kind of finalize that proposal. Next slide. We're also going to be talking about breast reduction for macromastia that's causing some type of pain. That came from the Ombuds office because of several different people who've reached out to them because of lack of coverage. I'm still in the midst of reviewing that. So if any of you have any interest or any input on that, please let me know. We looked at again at the maquette procedure for patellar dislocation. This came up as a CCO question. We just reviewed this recently and didn't find evidence that this was effective. It has a lot higher rate of complications than other treatments for patellar dislocation. So we decided not to add coverage a couple of years ago. And since it's such a recent review, we're not going to be re-reviewing it. Another CCO question is whether or not we cover foraminal stenosis in guideline note 37. Specifically, that guideline was written to say you had to have central canal stenosis, not foraminal stenosis. So as written, the guideline would not cover foraminal stenosis. I'm looking at whether that's still appropriate or not. That will be on the March agenda as well. Another thing that's probably actually not going to come to March because we're working behind the scenes on this is remote patient monitoring. We currently don't cover a lot of the codes because when they were new HCPCS codes, CMS didn't have rules or coverage. They now do, but we are, the proposal would have things like you can't do the store and forward code unless it's co-billed with a code for medical decision-making. There's a lot of work that needs to be done to see if we can make 2 codes have to come in together and a few other things. So keep an eye out. This will probably come to May unless we can kind of put it all together before the March meeting. Next slide. Upcoming topics. These are things that are on my to-do list that didn't make the March agenda, updating our tonsillectomy for recurrent infection guideline, whether or not we can limit pulmonary rehabilitation for long COVID. We're still waiting on some guidance about whether we can limit any service for long COVID. Ultrasound screening for breast cancer, we're waiting on the USPSTF guideline. Non-24-hour sleep-wake disorder, this came to us from PNT because there's a new medication specifically for this, but I'm going to be looking at things like light boxes for that. Coronary artery calcium scoring, we currently don't cover this. There was a really nice meta-analysis that came out in JAMA showing that it didn't add anything to traditional risk scoring with, for example, blood pressure and cholesterol levels. However, that article has been embargoed for errors, so we are awaiting its final publication before we take it up. We're also going to be talking about adding YAG. Sorry, I can't exactly remember what the acronym YAG stands for. It's a type of laser treatment for hidradenitis suppurativa. There does seem to be good evidence this is helpful, but the dermatologists are going to be joining us to talk about that in May. And on our future agenda, at some point, will be gender affirming care. Next slide, please. So the March HERC meeting at this point will just be looking at the VBBS topics. We don't have anything additional on their agenda. Next slide. The evidence-based guidelines subcommittee. I was told I really need to highlight this all for you. So they, at their last meeting, they discussed bariatric procedures, and the proposal that's coming out of EVGS is to add coverage for adolescents, but not add coverage for people with a BMI under 35, even if they have comorbid conditions such as diabetes. This is open for comment. Written comment can be, there's the email address and verbal comment. You can see the link there. Please, if you have any interest in this at all, please look at this and provide comments. There's quite a bit there, and it would be a significant possible change. So we would love to hear what you all have to say. Again, these are the links for providing comment. There is a draft proposal for continuous glucose monitoring that's going to come to the April meeting. That should be out for you to review 30 to 28 days prior to that meeting. And then there's also continuing work on chronic disease management programs, and I believe that's slated for discussion in September. Next slide, please. There is the generic HERC email address. And as Lisa pointed out, we have changed domains. As far as HERC staff know, we have not been informed yet that our domain is changing. So keep an eye out. Currently, our DHS OHA emails are still the correct email, but the herc.info has changed to the oha.oregon.gov. Questions, problems, any feedback from what I presented, or new issues or other things that you want to make sure that are on my radar or on my to-do list? And you know how to get a hold of me.
I'll give you things on my to-do list. How about that?
Mine's long, but
if CCOs don't have anything for Ariel for her to-do list.
I see Doug's hand up.
Okay, Doug.
Hey, Ariel, thank you. This is pretty in the weeds, but just a question regarding the urine drug screening, expanding to the 8 to 15 drug classes. You said in some circumstances that's going to be covered. Is there going to be a guide note, or is that just opening up the code?
I'm sorry. It's opening up the code.
Okay, thank you.
Yeah. We decided it's still the same criteria as we had before. So there's a number per year, a number per, like all of those sort of criteria, they're still in place. But basically where you could bill the 1 to 7 codes, you can now bill the 8 to 15 codes whenever that's appropriate.
Thank you.
Holly Jo said that she's already shared her to-do list with me. So
But
And
there's
actually, this is so one of the issues that Holly Jo has been asking us about kind of goes along with our cancer genetic testing group. It's more about symptomatic kids and when those tests are appropriate, et cetera. So if anyone else is having any problems with that, let me know. I kind of want to know the extent of what's going on and what kind of issues you guys are running into, because we might be able to extend or expand our cancer genetic work group to maybe look at, or maybe convene GAP earlier and have them give us some feedback on the symptomatic children and who are being tested and what kinds of tests and how to do that. And please go out and look at our bariatric surgery coverage guidance. That was Amy Cantor's plea. She wanted you all to make sure you're aware of that and that you look at it.
Is there a certain date by which that needs to be done?
Yes. Yeah, if you could go back to the EBGS slide. I think it's the one right after this one. Yeah, it's through March 8th. So you have a month, but don't hold your fire.
Hey, Ariel, this is Daphne. It's through 8 a.m. on March 8th.
Oh, thank you, Daphne.
You bet.
I will put it in my QHOC follow-up notes. So when I do the, what I usually write, like the homework notes. So let me try that. 8 a.m. March 8th, Daphne.
Yeah, that's right.
Thank you, Daphne.
All right, well, you know how to get a hold of me. I don't want to keep you guys from your break.
Well, I will send you my to-do list. Don't worry about it. And I'm sure there's other medical director lists coming, not just Holly Joe's. No. Okay, let's see here. Anything else for the good of the order before we go on break from anybody? Then let's go ahead and go forward a few slides. Just a reminder, we are going to be coming back for Oral Health Integration Learning Collaborative. We will take a 10-minute break and we will start back at 11 o'clock. Please don't put us on hold. I do love a good classical music, but not this time. So please mute your lines and we'll see you all back at 11 o'clock. Thank you. Welcome back. Right on the dot, 11 o'clock. Can you hear me okay, Laura? I can't hear you.
Yes, we can hear you perfectly.
Okay. I was looking to the other Laura, but I'll take any Laura at this point. Welcome back, everyone. We are going to go ahead and get started for the Learning Collaborative. This is, again, Lisa Bowie, your Quality Improvement Director. We are going to start with the introduction, and then I'm honestly just passing it over to your oral health chair. So we are going to talk a couple different parts of oral health integration. So it looks like we're inviting. Let's give it a few seconds here while we admit some folks that are just coming in for the Learning Collaborative. So just give it a second here and let's make sure we even admitted everyone here. Thanks, Jennifer and Ann. You both are co-hosts, Jennifer and Ann, so you should be able to admit anybody that continues to come in just for the Learning Collaborative. So if you could keep an eye on that, that'd be great. So when we were talking Learning Collaboratives, oral health integration came to the surface, and Oregon has been a part of a specific initiative with CMS. So I'll be talking a little bit about that, but I wanted to go ahead and turn it over to your trusted oral health QHOC chair, Laura McKean, down at All Care, and she'll do the opening, and then we'll cover a little bit about the agenda. So go ahead, Laura.
Thanks, Lisa. Can you all hear me okay?
Now we can.
Okay, perfect. Thanks everyone for joining this learning collaborative. We haven't had an oral health learning collaborative in a while, so we decided to bring this back to the group. And today we're going to talk a little bit about fluoride varnish applications, and my friend Alexa Jett from Care Oregon is here, and she's going to be talking about that with her her partner Brittany. And then after she's done, I'm going to talk a little bit about oral health integration within a primary health and behavioral health clinic. So I appreciate everyone being here. Like I said, we really want to kind of make oral health right up there with physical and behavioral health here at QHOC. So we're going to look at bringing that back on a regular basis so we can keep you all up to date. You know, we're very lucky in Oregon that our Medicaid population has adult dental benefits. We're one of few states in the US that actually has the expanded dental benefit. And we hear all the time, Alexa and Brittany, and this is Kelly, my partner, we hear all the time how amazing and lucky we are in Oregon because our folks have adult dental. And Hawaii actually just got adult dental benefits a couple of weeks ago, and they've been working a long time. So we're going to talk to you about oral health this morning. Again, thanks everyone for joining us.
Thanks, Laura. So as you all recall, my past life, I was in a federally qualified health center that was actually integrated, that had oral health, behavioral health, and physical health. So this is a passion of mine as well, of finding those areas in which we can treat whole person care, whether it's adult or children. So today we'll be covering one of those specific areas of which I too have had that experience. They used to call me Mrs. Bowie for the children that would come into the clinic. They would see me and they go, "Hi, Mrs. Bowie," and I'd be like, "Oh, look, my little children," because they were getting their teeth cleaned, and then they'd go see and get their immunizations. And so they only saw me as the child that would be, you know, teaching them technically math when I volunteered in the school. So again, the individual themselves, the children, they, you know, I go teach them and tutor them in math, and then apparently I go get their teeth cleaned, and then I would go walk them down and get their shots. So it's still just the one little kid that's just so excited, and I'd be like, "Great, let's go get your teeth cleaned." "Oh, and great, let's go get your shot, and then, you know, I'll see you on Wednesday and tutor you in math." So it's the whole person, and that's the whole person education, the whole person teeth, or the whole person in preventative health and teeth. And technically, Mrs. Bowie is going to get you on all of it. So we are going to talk about how we can do oral health integration in today's little next 90 minutes. We're going to cover the Oral Health Affinity Group. That's my part. And then I'm really going to turn it over to a couple of y'all in the practices to cover some specific projects. And then we'll just kind of wrap it up. We are going to do the two projects for presentation style, and then question and answer, presentation style, and then question and answer. So we really felt that each project is kind of distinct, and we'll do the Q&A after each one. So if you're wondering when's the Q&A time, it's going to be after the topical fluoride varnish one, and then topical or the oral health integration behavioral health. So Q&A will be after each section. Let's go ahead and go to the next slide, please. So I'll go ahead and give an overview of some of the work that's been going on in regards to oral health integration. It's not, again, for each one of these projects, but just kind of a high level of some of the work. And then if anyone has any questions about any of this, you can reach out to myself and I'll connect you some of our oral health policy team here at the agency. Next slide. So we are been a part of this for a few years, which yes, it's quite difficult to do this. We all know quality improvement work during a pandemic, but it has been carrying forward. So CMS started an oral health affinity group, and it's a CMS-led group across 14 states, including Alaska, California, Idaho, and Washington, and Oregon. It's specifically for caries prevention with a focus within topical fluoride varnish in primary care. Oregon tied it within our work around kindergarten readiness, specifically at the time when we had the incentive measure. So it was at the time when we signed up, we had the actual incentive measure portion with the kindergarten readiness metric. Recent change in the metric to allow for the topical fluoride varnish to count in the numerator. And then the actual affinity group work was for technical assistance and support and moving a quality improvement work project forward. There were no actual incentive dollars or no additional dollars tied to the work. Next slide. That technical assistance is inclusive of OHA, but it also is inclusive of any participants, whether it be OHA or CCOs or DCO or any other partner that came along with this work, was for the Institute for Health Improvement Open School. So IHI. So IHI Open School series was basically afforded to any participant of the affinity group. So individuals of the actual affinity group were given, or basically access to this open school. And as you were going through your affinity group project, you were using the open school practice and methodologies with it. Next slide. This is just kind of context of what the commitment was basically on the OHA side and the affinity group participants. It's just really context, not really anything. It's still kind of going on and we're kind of going through the phases of it, but this is just so you had some grounding of what OHA and the affinity group members were doing. Next slide. Here's a storyboard presentation. So regularly the affinity group, as well as so whether it's across the states, OHA regularly meets with CMS, and technically the affinity group meets, within the affinity group participants meet across the states, and then we meet with CMS, and then within Oregon, the partners meet. So this is a storyboard visual that is used for that convening. So it just kind of is a who, what, and where. Next slide. The next slide is really the current state, so we'll just skip to that one so you can kind of know what we're doing. So what we have changed to kind of reflect where we're at is, instead of meeting monthly, which is what we were doing, we're now meeting more one-on-one with the participants. We have 4 CCOs remaining in the affinity group, represented by 2 organizations. One other CCOs is working directly with 35 clinic organizations within their 3 regions. They've created a comprehensive toolkit for primary care, created member-facing materials on how to get dental into primary care. So these are kind of some of those interventions, basically. And this is, again, like what we work with the CCO and or partners, and then how we kind of work with the other affinity groups and spread knowledge. Are there any barriers that you're struggling with? It's really how to connect partners for peer learning. This is, again, one way of doing that, but we'll continue to work through that as well as with other affinity partners. And then implementing quality improvement tools and spread and scaling up as with any quality improvement. And doing that within, workforce and or pandemic. That's always, as we come out of the pandemic, how we do that on the breadth of and depth of workforce. So we are trying to balance the needs of the the system. So that is the current state of the affinity group. We will take questions about the affinity group directly to me at any point in time. Sarah Weatherson at OHA Transformation Center was leading the affinity group, still kind of in the part, but she transitioned to a different position. And then we have Carolyn, who is now our oral health person, who is working on that space. So I'll go ahead and take any direct questions about the affinity group. You can just email them to me and I can connect to the right parties about that. I'm going to transition over to, I think, Alexa and Brittany. Does that sound about right?
Correct. Good morning. Still morning. Okay. So you can hear me, Lisa?
Yes. And I
Okay.
think you need to share your screen. Do you need to tell me when and...
Oh, I thought I was told that you'd have the slides and you'd screen share those.
Oh, okay. Do I have the slides? Do I have them or does Jennifer have them?
This is Laura Krieger. Yeah, they're in the combined slide deck. But if
Great.
he wants to walk through the PDF later, that's when she'll need screen sharing if you would like.
Okay.
We can see the slides though, Lisa.
Yep.
Okay, so Brittany, if you need at any point in time to share your screen, you just let Jennifer know.
So great. So next slide, please. Is this okay? Perfect. Great. So hi everyone, and thank you QHOC for inviting us to come today. I'm Alexa Jett, she, her pronouns, and I am the director of Oral Health Clinical Services. And Brittany and I are here representing Columbia Pacific CCO, Jackson Care Connect, and in partnership with HealthShare of Oregon. I'm an expanded practice dental hygienist with 15 years clinical experience in both private and public health settings. And I've been with Care Oregon's dental department for the past 7.5 years in various roles, supporting our dental plan and our FQHC network. But for today's topic, supporting oral health integration in the CCOs. So next slide, please. While we also have oral health integration initiatives for maternity and patients with diabetes and chronic conditions, today's focus is on prevention pediatrics. And I did want to point out that, and you'll see in a slide or two, that this work has been ongoing and a major area of focus at Care Oregon enterprise-wide for the past over 6 years, and isn't directly related to the affinity group, but we are happy to be a resource to others interested in oral health integration for pediatrics and beyond. We know that people are prioritizing physical health and are more likely to seek care with their primary care providers right now. And so it's important to leverage those interactions for preventive dental services, providing oral health education to members and patients, and really key, establishing a dental home via some referral navigation pathway and care coordination. We see engagement at the primary care level as a key step towards the direction of the overall goal to get folks re-engaged with care across all types, and so that they have the best opportunity to get the right care at the right place at the right time. So with the focus on pediatrics, and a well child visit, we know that children are coming back to well child visits, and under the Oregon Health Plan, there are multiple services that are covered and reimbursed in primary care. So fluoride varnish application, a screening, which was added in 2022, and oral assessment. Those can be standalone. However, there's also the value in providing education and the ultimate goal in referral to dental services to establish that dental home. In addition to providing the services, we also know that there's a need for more transparent and efficient data sharing between healthcare providers in supporting members' total health. That sounds like it might be easy, and I think everyone in this room knows that that is actually quite a large project and undertaking. But that is another area of focus as we are in this transformative space right now. Next slide, please. As we look here, we've got some data sets that we wanted to review, focusing on children ages 0 to 14 receiving oral health services across the CCOs. And the first two data sets are fluoride varnish claims, of which there's 2 codes that are covered services in physical health. And then also oral assessment and screening, 2 other separate codes. And these are for our Care Oregon, Columbia Pacific, and Jackson Care Connect physical health plans. You can see in orange, prior to the public health emergency, we had claims coming in. And then you can see in 2020, they backtracked. Of course, we would expect to see that. 2021, we start coming out of the public health emergency, but it was really here, 2022 claims, that we can see some more dramatic improvement in utilization of those services. And we'll get into a little bit of why. The third data set, that's not claims-based. Those are actually dental care requests that we have received through a navigation portal that we've stood up here for many years for any of our Health Share, Jackson Care Connect, and Columbia Pacific partners to use. And dental care requests, you can think of that similar to a dental referral. A referral is a closed loop system when you say that to a provider network, so we call it a request. And you can see again in 2019, where we were receiving a lower amount here over the past few years, including even with the public health emergency, we can see an increase in those referrals coming into us. And what we do with those is we are working very closely with our dental care organizations, our dental plan partners, and provide them the data, and then they can outreach to those families. And in addition to scheduling in dental and establishing that dental home, they can provide help with interpretation services and NEMT. Next slide. So how did we get here? This is actually something I'm so excited to share. So starting with our journey in 2017, it was executive level leadership at Care Oregon, enterprise-wide cross-regional alignment to land on some key initiatives for oral health integration, one of which is for children ages 0 to 5. We knew we needed to have that leadership buy-in. From there, we have the dental innovation specialist role in the dental department, expanded practice dental hygienist, myself and Brittany, and we were both First Tooth trained. This is back when First Tooth was the sole program really for integration in primary care for children. You can't take a dental person and put them into primary care though and say, hi, integrate these workflows. It doesn't work that way in a network, and it doesn't work in a clinic or even within our own organization. Brittany and I have strong relationships within Care Oregon in our different regions with our physical health, our behavioral health teams, and also with our teams that support community benefit organizations. There is internal upskilling that happens between both teams so that we can be integrated in order to support our networks. In doing that, we created resources, and over time you get feedback. So we have quality improvement for our provider resources and even our internal resources for our own upskilling. These resources also included, or the quality improvement also included enhancing codes to allow services for more ages. That way, even the oral assessment could be aligned with the DHS metric, and also alignment with the CCO quality metrics for prevention dental services in the 2 age bands. So as we're working on that, then in 2022, Care Oregon enterprise-wide introduced oral health as part of their value-based payment model, and that was implemented for oral health services provided in physical health. 2022 was a pivotal year. You could see the data. There were multiple increases in our claims and our dental care requests. At the same time that the value-based payment was implemented, we also heard from our partners that they would love to have more resources. They also didn't have very much bandwidth. We know that the staff shortages are continually affecting not just our own organizations, but those of our network. So we created and vetted and developed member and provider facing resources. And as we're putting those together, the light bulb went off and Brittany said, we have so many different tools. We have so many different workflow examples and now our resources. And what can we put together in one comprehensive and robust toolkit? So that's how the integration toolkit came to be. And the last step that we have for that, not only was it shared with OHA and our partners, we have oral health integration toolkits, not just for pediatrics, but for maternity populations and for patients with diabetes. But now those are on the website. They are living documents, so we are constantly ensuring that that the information is up to date, and quality assurance and quality improvement. And before I hand it over to Brittany, she's going to go and highlight some of the key areas that you might find of interest in our toolkit. I wanted to explain that when you look at it, you can see that there's areas for technical specs and recommendations and our own embedded materials, our resources. But really, this is the ultimate guide for implementing oral health in primary care. And it's infused, it's basically a labor of love, I would say, and it's infused with the hands-on knowledge that we have and lessons learned that we have from the past 6 years. So as I hand this over to Brittany, Brittany's another resource that we have in her role, and it's key in order to implement. Not only do you need to have leadership buy-in and bandwidth in the teams, but also that trust and a partnership, and Brittany in her role is able to provide that to our partners as well. So Brittany.
Thank you, thank you. So yes, Lisa and everyone, I will be sharing my screen. It looks like that's already turned on for me. So, oh, it's not, it says it's disabled still. So if someone could get that set up so I can share the toolkit really quick.
I think I just did it.
Awesome.
Can you try again, please?
Yep. Thank you, Lisa. Okay. Is everyone able to see the toolkit?
No.
Not yet.
It says you have to go up to view options at the top and that drop down. And
okay,
then you
something just showed now. Now I can see something different. Not a slide.
Now.
Okay, is the toolkit up there though?
A pediatric oral health integration toolkit that's showing on a website.
Yes,
if that's what you want us to see.
Yep.
Okay,
perfect.
We're good.
Thank you. So hello, everyone. I'm Brittany Trujillo, also an expanded practice dental hygienist. I've been at Care Oregon for 3 years now. Much of my work encompasses supporting our networks of the 3 regions on oral health integration. Prior to my work here, I did provide clinical services across various community health settings. And so my overall ethics and mission in my career has definitely been community and public health. And of course, oral health integration is an integral part of that. So Alexa did mention much of what's already in here, but this is really just an all-encompassing document of our materials. We realized with oral health integration growing so rapidly, all the services that can be provided, I was sending out pretty large emails and lots of PDFs and documents in those emails at times to clinics, and it can get kind of messy. So in creating this, it has been so helpful as really a one-stop shop for clinics and staff to really access it, review it, save it, share it amongst their other clinics and staff, and really help with implementing oral health services in primary care under the Oregon health plan. So within the toolkit, we have lots of different options. Let's see if I can zoom in a little bit. I don't know if it's looking kind of small on your screen. This is our table of contents. Everything really hyperlinks within here to embedded documents or chapters, etc. In an effort to save some time, I won't go in depth within most of these chapters, but we'll review them all very briefly, but I'll stop on a couple that partners have found most helpful in implementing oral health services. So chapter 1 and 2 really just provide some background information on oral health services in primary care, as well as exploring and navigating options and what implementation can look like. As you can see here, we have some hyperlinks to things that we've created, tools for clinics, like oral health integration readiness tool, implementation checklist. So very start and basic of oral health integration. and background in these chapters. One of the chapters that is most important, possibly the most important chapter, is Chapter 3, our Oregon Administrative Rules and Billing and Coding. Many clinics and providers are still unaware of all the oral health codes that are reimbursable in primary care settings, especially billing departments. When they find out, they're usually surprised that many of these codes are dental codes. We give specific information on periodicity, DMAP rates, and like Alexa mentioned, also where Care Oregon has enhanced any of these codes above the basic benefit to allow providers to really open up those services to more of our members. Prior to the additional screening code this last year, which has been very helpful for a lot of our network partners in implementing oral health services, much of the work that I provided and historically that Alexa provided was technical assistance, support, and training on the traditional first tooth program, which we have still included in here as it's important and some clinics may want to explore and implement that program itself. This chapter highlights the requirements and provides all the additional information on that program if clinics are interested. Chapter 5 is another one of the more important chapters here in the toolkit. This is where we highlight Care Oregon's developed oral health materials that really supports the clinics in discussing oral health with their patients, but also to provide some tangible materials to distribute and reinforce their conversations with patients regarding their oral health. We offer to print these materials free of charge upon clinic request. We have them in multiple languages, of course. And also in this section, we provide links to various professional associations, their policy statements, clinical reports, recommendations for oral health services in primary care, as well as fluoride varnish safety information that we tend to get asked a lot of questions and for a lot of resources, so they can have a bit of extra information for patients, questions that might come up in discussing oral health. Part of our resources section, I know Alexa already mentioned this, but I am also a resource for our network partners. As much of this toolkit is to provide guidance and to be a one-stop shop, Alexa really covered it, but we know that clinics still need support in workflow development, staff training, claims and data review, and much more. So we definitely want to support our networks and not just be disseminating a toolkit in hopes that they can make it work off of this. We want to provide that one-on-one support where needed. And we still encounter many, many questions almost on a daily basis from our networks. This is new to so many folks. And so it's been really rewarding to help the networks in implementing this. Finally, I would like to highlight the last most important chapter, dental navigation section. So navigating the healthcare system, as you all know, can be difficult, just as difficult for providers actually as it is for our members. We are aware of the multiple challenges and barriers that even co-located FQHCs face in creating a referral system for their primary care and behavioral health clinics to dental. And so we provide support on that as well. Then we also know outside of co-located FQHCs, our pediatric and primary care clinics do not have a referral system in place to get their patients connected to dental services. Care Oregon's solution, Alexa also mentioned, we created the dental care request. It's really a quick and easy form with basic patient and clinic information that's inputted into an online form within our provider portal. And that's sent on to us, and it can be for any health share of Oregon, Columbia Pacific, or JCC member to get connected to their dental plan. So this has really supported the networks in navigating that dental piece to get their patients connected to dental, where there's not a traditional workflow or streamline in place. The last little chapter is just to mention that we know and value data transparency, and we share reports with our partners on a regular basis. And we are currently building out multiple dashboards that I'm excited about for the clinics to access on their own and see their efforts and success in live time. So we'll be updating this section in the near future to include information on that. Now, I did mention everything, all those little documents kind of hyperlink to the embedded documents at the end here. And so I'll just scroll through some of these. We don't need to stop on these. I know we're pretty short on time. I just want to highlight our provider and member materials that we have embedded in here, that were also hyperlinks up in chapter 5. So before the actual toolkits, we developed a portfolio of materials, so oral health brochures for both providers and members, not just for pediatrics, we have it for patients with diabetes as well. We received lots and lots of feedback that clinics were needing some sort of resources and materials that they could use to give out to patients on oral health and really reinforce those conversations. So this is our provider brochure that we have. And we really just wanted to include information on all ages, all stages. We wanted to have consistent messaging to support state metrics and best practices. And so we really wanted to create also, I need to zoom out, something that was fun. So I'm all about fun here. So I was really obsessed with the member one and got to work a little bit closer with our brand marketing and engagement department as I really wanted to see this one through. So this is our member brochure. And again, going through ages and stages. So it's important to be able to have conversations no matter the age in primary care. Even though the focus, much of it being on pediatrics, it's definitely important to cover as much as possible in what we have. And so that is our member brochure. And I know I went over a little bit, so I'm going to wrap it up. But if there's questions, I know that we are also online for that as well. Okay, Lisa, I think I stopped sharing, so there we go.
I was going to see, I was just, thank you so much, Brittany. Number one, I was actually just on our website with your slides. And it looks like the hyperlink doesn't work for where the toolkit is. And so I'm already thinking of the questions that people are going to ask me, which is how do they get their hands on the toolkit? And apparently the hyperlink on the slide doesn't work. So maybe if you wouldn't mind dropping the link in the chat, and then I'll obviously fix the slide that we uploaded on the QHOC website to make sure the link works. But if you wouldn't mind dropping it in the chat, I'm guessing everybody on this call would love to go through that toolkit themselves. But for just as a reminder, you can drop some messages in the chat. You can raise your little hand on the reactions button, or you can just go on camera and then I go and say, hey, whoever, would you like to go ahead and ask your question? So we're going to ask questions after each presentation. So now is the time to kind of ask your questions for Alexa or Brittany.
And I'll say that the link is for the Care Oregon branded toolkit. The toolkit's also branded for JCC and for Columbia Pacific and are on each of those websites as well. But to make it streamlined today, we were just sharing the Care Oregon. It's the same material, just the branding on the resources is updated.
Perfect, thank you. And I think the one that was on the slide was for Care Oregon's branded one. It just, for whatever reason, maybe when we uploaded it to the website, the hyperlink didn't work. So thank you for dropping it in the chat stream. What are people's questions?
Hi, Lisa. This is Uberka with ODS. And I just have a question. So I see it's the tool you presented the toolkit. Now, is that available to sort of any pediatric clinic that wants to participate? Or who is that available for, I guess, is my question.
So it has been created for any provider. I mean, it's out there now on the website. So, and I've got this horrible lag, so I'm sorry. But it is when we are outreached by a partner, then around oral health integration, we will direct them with the toolkit and provide some additional guidance and have some conversations with them. So it's used as a supplemental resource. However, it could be a standalone resource. So it is open to anyone who's interested, as it's out on the websites now. But Brittany, I believe every time that we have a conversation, an initial conversation with a partner, that we provide the toolkit and also for if patient or partners are interested in the diabetes integration and maternity integration, correct? Yeah. Did that answer your question?
Yes, it did. So it's just available for sort of anyone who's interested, but also for any partner clinics. And when you say partner clinics, I would assume not just with Care Oregon Dental, but sort of within the Care Oregon umbrella.
Actually, this isn't aimed for the dental networks. It's all primary care focused.
Right.
So So sometimes we do have our Care Oregon dental partners are interested in it, and I'll say that's fantastic. And there's nothing in there around like a dental dental codes or anything like that. But we're there to support integration between dental and medical as well in the co-located partners. But yep, it's out there for any partner that's interested.
Great, thank you.
Yeah, you're welcome.
Paul Walker.
Yes, good morning. Paul Walter with Trillium Community Health Plan. I just have a quick question for you. Do you have any examples of any providers who have maybe decided not to participate in a program like this? And if you do, any barriers or feedback that they gave you why they haven't participated?
I would say, and yes, it actually happens quite a bit, or you have somebody interested within an organization and they reach out to us, the organization reaches out, and we provide technical assistance and all the materials, and then it stops. And that could be because perhaps you have somebody in a clinic position, a staff level position that's interested in oral health integration. However, it hasn't become a organizational strategy, and it hasn't been dedicated time or resources from a leadership level. And then vice versa, sometimes we have leadership level say, well, we want to implement oral health integration in our system and make it happen. And then it comes down to clinic level and to other management levels, and they do not have the bandwidth. And there can be a disconnect sometimes that we can see, and timing and communication, I think, plays a big part in that. So what we'll do is provide our resources, create those relationships, and then say we're available whenever you're ready. And sometimes it's a few months later, and sometimes it's a few years later.
And this is Laura, I'm just going to add another layer to that, Alexa, and give another different example. Sometimes it's not, sometimes it's the provider. And I'll give you an example. My daughter took her 9-month-old into the pediatrician for a checkup. And I mean, I'm always on it, fluoride. And the provider would not write her a prescription for fluoride tablets. So sometimes it's just the provider in that particular setting that doesn't want to do it. Then you find someone else.
Hopefully the organization has that directive at some level, but you're right, it can come down to provider philosophy and preference.
Thank you, Paul. Other thoughts and questions?
I can add also a follow-up to that last question, Paul. In over the past 6 years that we've been providing integration support, you can have a clinic partner implement and successfully implement based off of claims, and then the whole staff can change. and that knowledge can walk out the door. The initiative can walk out the door. And so sometimes we start over again. However, we know that they've already designed successful workflows. So then it's making sure, is that team at a place where they can implement again? Are they on board to do that? And then how can we make quality improvement adjustments to those perhaps now outdated workflows and then get them set up for success again? But that's actually happened a few times over the years. And then that raises a flag. Why is this once high performing oral health champion clinic now not performing at all? And then when we investigate and connect with them, it's because there's been staff turnover.
Yes, thank you, Alexa. I appreciate you saying that, because I believe that to be the case as well, is that once you establish a good workflow, like anything, if you don't keep your finger on the pulse of it, it can begin to disintegrate and fall apart over time. So I do see that as a reason why, especially Trillium as well, for our initiatives, we want to continually provide them this initiative and remind them, not beat them over the head with it, but of course, remind them of it for staff turnover, which is inevitable. So I appreciate that feedback.
I think this is Lisa at OHA. I think that goes back to, you know, this integration work is not, it's not ingrained in us yet, right? As far as practice goes. And these processes and workflows, I know even when I left my integrated practice, where, you know, I was crossing my fingers that the processes that I set up were still part of their daily work, that as the oral health integration champion, if I left, well, I did leave, not if I left, when I left, that those practices were still, and processes were still going to just happen, that the carries work around the work between the children with well child visits and immunizations and child recall were going to happen, because, you know, the EFTAs were going to automatically work with the MAs with the prevention work that needed to happen, right? Because there was data reports. But it is upon the processes that you set up, and your readiness assessment tool, I think, gets to some of it that I'm looking at. Have you had that happen, Alexa and Brittany, when in your toolkit? I noticed you have that readiness assessment tool and you talk about champions. What have you experienced when you're going out with your practices as far as people utilizing that part of the tool, as far as readiness assessment, going through finding champions, finding those processes established? Is that been a crux of successful outcomes or not in integration?
Brittany, do you want me to take this one? Okay. And join me. So it's partners can come forward at different levels of readiness. And some we have the initial discussion using the readiness assessment, and it's a lot of aha moments of, oh, okay, we need to go back in and talk this through a little bit more. And then there's others who come to the table already identified with an internal strategy on how to implement, and they just need to fine tune it and have some of those resources provided, some guidance, usually around the OARs and billing and coding, understanding codes, especially if they're a dental code that can be reimbursed in primary care. So we've seen both, I would say, over the years. And real quickly, I want to address the comment that's in the chat around parental application of fluoride varnish as a potential additional solution. I'm going to put on my dental network hat. For Care Oregon Dental, Brittany and I supported a preventive dental services teledentistry visit project in the metro area with 3 FQHCs around sending out a preventive oral hygiene kit to patients when they were scheduled with their dental provider, and that the dental provider had a televisit in which then they could observe the fluoride varnish application being applied to the child's teeth. And that is the lens from dental. And in integration, the well child visit is not a a televisit. So Brittany, please join in here, but that is not a service that is generally provided in a telesetting. And so that fluoride varnish application has been in person in primary care. But I think some of the other dental plan partners as well, who may be on the call, have also implemented during the public health emergency a kit that could be sent to the parent and guardian in advance of a remote video televisit in which fluoride varnish could be then applied at home.
Other questions?
Lisa, this is Courtney. Can you hear me? Okay, great. I just wanted to say thanks to Alexa and Brittany for sharing. That was really awesome work that you guys have been doing, and really appreciate you sharing it with us. You kind of touched on this in your last comment around barriers to billing, and I was curious if there were any specific barriers, especially around those D codes, the dental codes, that you experienced, and how you addressed it outside of, you know, the expanded reimbursement process that you put in place.
I know Brittany and I always at the initial conversations with partners explain who else needs to be at the table to understand that a provider can encounter a D code, one of these sets of D codes, not all, right? What is needed for documentation in order to be reimbursed under the Oregon administrative rules, and then who needs to know that? Because early on, we learned a lesson that we learned working with a partner. They implemented, and we said, well, we don't know unless we see the claims come through, right? We're the health plan. And we'd investigate. And it turned out that sometimes in billing departments, people would hold those D codes separate, and the messaging hadn't come to them. So moving forward, Brittany, don't you have at some of these initial meetings nowadays, like actual dental department, or billing, excuse me, not dental department, billing department roles to come and attend?
And depending on the EHR, sometimes you need the EHR site specialist as well, because something might need to be built out. That's more what we found recently with a handful of partners, is like Alexa mentioned, where there was a whole backup of these codes, and it was something needed to be turned on within the EHR. So every time we gather information on things like that, we make note of it, so we can share it in those initial meetings. So hopefully there's no hiccups.
I would say that's the biggest thing, Courtney, is that even though it's written in the toolkit, right, you need to have sometimes that validation from a human being. And so Brittany's the go-to for that, oftentimes via email, and then we can help clear it up. And sometimes it's more like you're a private investigator, where we say, well, we can't see inside your own systems. This is what we see. So can you take a look at X, Y, and Z? And then they come back and go, yep, was turned off.
Right. Yeah, that's super helpful. Thank you both.
Is somebody speaking? I'm not hearing that.
No, they're not, Jeannie. I think everyone's probably looking through the toolkit like I am.
Oh, okay, that's fine. I don't mind.
Any questions?
Like, yeah, where are we going here, team? You know, moments of silence make me nervous. I'm like, come on, somebody has to talk.
We have a few more minutes for questions for Care Oregon / JCC Columbia Pacific.
Did you see, did you address or see the question in the chat from Dr. Rajani?
Okay. Yep, they
okay,
got
good.
it.
Okay, good. Just making sure. I thought I might have missed that.
there's so much in that toolkit, Alexa and Brittany. It is like some good information. As I'm still reading it too. No, which is I'm sure what people they're just scrolling down and I'm clicking the links because I was like, oh, let me click the readiness. That's how far I got. Let me click the next one. Although it also makes me want to go back to my FQHC days. So I mean, I should probably stop clicking because at that point, I'm just going to quit my OHA job and I'm going to go back and work in practice, which is where my heart is. So I don't know, maybe I should stop clicking the toolkit because I'm going to like want to go implement your toolkit, which is some great work. Thank you so much, Alexa and Brittany. I'm going to go ahead and everyone can continue to use that resource, but we're gonna transition. Jennifer, if you wouldn't mind pulling up the slide deck, and we're gonna transition over to all care and give our attention back to all care, and we're gonna talk about oral health integration in the behavioral health and physical health setting now. And at some point, we will all be digesting our little eyes into that to the Care Oregon toolkit, and we will learn here about oral health integration and behavioral health, physical health, and then we'll open it back up for questions. And I believe Care Oregon is staying on the line, so if you come up with more questions for them, we can always circle back. So Laura, you have the floor.
Thank you. Can you hear me okay?
Yep, you're good.
Perfect. Okay. Thanks, everyone. We kind of have a saying in the dental world that oral health is important from the womb to the tomb. And so that pretty much covers everything. Thanks Alexa and Brittany. I have the opportunity to work with Alexa and Brittany and have learned so much from what they're doing at Care Oregon. So I really appreciate them sharing. So we're going to kind of transition over to more of the older kids and adults. And we're going to talk about having an oral health provider in a behavioral health and physical health setting. So if you can go ahead and go to the next slide. And I'm Laura McKean. I am the Director of Oral Health Services here at All Care. And I am joined by Kelly Beaumont, who I call my partner in crime. And she's the director, she's a community outreach person at Capital Dental Care. And I've had the opportunity to work with Kelly for quite a few years now. So we're really excited. We're going to chat with you a little bit about the project that we have going at Options for Southern Oregon, who is our manages our behavioral health network. And Capital Dental Care is who Kelly's with, and she's the hygienist that is involved in this project. So next slide. So we talk a lot about why we want to integrate the three categories of health. And, we've all heard this before, oral health is separated sometimes. It's viewed as a different part of general health, even though we all know it's a part of overall health and well-being. And for those of you that remember Senator Alan Bates, he was a huge champion for oral health, and he always said that the mouth is a part of the head, which is a part of the body. And I've used this example before, but he had a patient that was in ICU for a few days and could not figure out what was causing him to be septic, and turns out it was a dental abscess. So he was like I said, he was a huge champion for oral health and this work that we're doing. And also, behavioral health providers, they're in a position in their clinics to offer intervention for their patients because they're seeing their patients regularly. And so we have tried to use some tools to do some education. We want the providers to understand what their members' needs are. And also, we all know that poor oral health, it increases problems with mental health and substance abuse disorder. And I'm sure we've all seen pictures of what can happen there. And if you don't have good oral health, if you don't have teeth, or if you have teeth that are not healthy, it's going to create barriers in your social life, to include employment, school, and self-esteem. Next slide. So what we did, we started a pilot project a few years ago in partnership with Capital Dental Care. And we talked to Options for Southern Oregon about having a expanded practice dental hygienist in the clinic a couple of days a week. So before we started this project, Capital was, they developed this survey that they sent out to the members at Options. And it was really just a few questions asking, you know, if there was a provider there, a dental provider, would you be willing to see this provider? Would you be comfortable seeing this provider? Do you have dental needs that are not being addressed? And it was overwhelmingly, yes, we would. So Capital got together and we worked with Options and Capital to implement this. And, you know, I will say it's not something that happens overnight. It definitely takes a few months to get implemented. But in Oregon, we're really, really fortunate that our hygienists have an expanded scope of practice. So they can actually be in the clinic without a dentist on site. And also, what we've really learned is that the hygienist becomes a team member at Options. So Kelly's not somebody that just comes in once a week, brings her equipment, doesn't interact with anyone and leaves. She really has become a member of the locations where she works, which has been really, really, it's been good for the staff. It's also been good for the patients there. Next slide. I'll let you do this one.
Advantage of integration is we're able to bring in our mobile equipment. And then I'm very flexible, like in the rooms at Options. I work around their space. I do currently use their exam table, so it's not as much of a big deal about moving their equipment around. And I always leave it the way I saw it when I came in, so I try to keep that. So we're not totally invading their space. We're like a guest there, and then over time you do blend in and become one of their team members, but I try to not make it difficult for them when I bring my stuff in. The other thing is the expanded dental benefits for the adults and integration funding model with the coordinated care organizations has made it possible. This has helped. I know at one time we didn't have some of that stuff, but we have a huge need in the behavioral health clinic with, I have a lot of homeless population, people that are looking for dental care and not sure how to access it and are able to do that through Options. Next slide, please. Some of the barriers are the challenges with the EHR system. You know, I've been over there for 4 years now, and that is, I mean, I'm not in their system. I have a separate system, but we have came together with our chart notes. We have built in things that they can put in for us. We're doing tracking as well. So you always have to come into these open-minded, be open to suggestions and changes. So it does keep changing over time, but it's super important to be open-minded with that. Oral health needs can be extensive for behavioral, mental, and substance abuse. Haven't seen a dental provider in years. And the difficulty navigating the Oregon health system, that's a big thing. I do help make appointments for them and get them into their dental homes.
Next slide. I'll do this. So we also realize the importance of care coordination when we're seeing these members. And you know, the goal of the program, we wanted to increase utilization and comprehensive dental care, both for Capital members and non-Capital members. So we wanted to make sure that care coordination was involved in this. And so Options, what they will do is they'll keep a separate schedule for the hygienist, and they will actually help make appointments. The practitioners at Options will do warm handoffs to Kelly. Same goes for Kelly. She can do warm handoffs, and it just goes back and forth. So it's a partnership. And Kelly makes appointments, like we said, directly in the dental offices, or she will refer, if it's not a capital member, she'll refer it to me, and then I will send it to the partner dental plan that we're contracted with to get them in. Next slide. So this is just a picture of the operatory at Grants Pass Clinic where Kelly is working. And I'll just let you describe a little bit about your interaction there.
So this is just kind of one of the basic setups we have in one of the rooms where we can bring, this is mainly for like if we're doing dental sealants and stuff on children. I would bring them back to my room. Everything else is done in into the patients, into the rooms where the doctors go into. Normally the fluoride varnish, the SDF, all that's done in the patient's room. But this is one of the rooms I do bring them back to do more preventive services.
Next slide.
This is the reception area at Options, the Behavioral Health Clinic. It's a small little reception area. There is 2 rooms as you walk through that door. I do take one of their rooms for the day that I am in there. We just kind of work around each other. Sometimes I do hop into the primary care room to do dental screenings, kind of if they're running behind or things are going on, I'm able to do that buffer as well. But we do send patients back and forth to each other.
And just a little explanation. So Hillside Medical Clinic is located within the Options Clinic itself. And so there's a different reception area for the Options patients when they come in to see their providers. And then Hillside Medical is embedded there within that.
Yeah, so sometimes they're like, there's 3 levels. Sometimes they're upstairs. They just got done with their mental health counselor and they'll come on down and see me. So a lot of times they have multiple appointments that day. So that works out well. They love being able to access the dental as well.
Next slide.
This is just kind of that basic setup where I was talking about. I can use their chair. It's a rather low chair, so it worked out pretty good. Some days I just have the very basic stuff set up, but you are building relationships with these people. You are getting them into their dental home. A lot of them have no idea how to access. It goes both ways. Sometimes I have people that are not even set up on OHP yet. I'm the first one they've seen, and then it's like, oh, maybe you need a primary care doctor, and I get them to that, or behavioral health. So it's interesting how you just never know, and they'll see the board out front and that kind of cues them in. Oh, can I make an appointment? And they send their other people they know in as well outside the community, and I can see everybody.
Next slide.
This is just kind of the basic setup. I do a lot of silver dynamine fluoride on these patients because they do have a ton of tooth sensitivity. And I'm talking sometimes it's every tooth I'm doing it on. They have a lot of broken teeth. So at least we're able to give them that benefit. I do have them, if they can return a couple of times, it's ideal. But at least getting that one application is key, just to get that bacteria down low. But that's been a huge success. So next slide, please. So the workflow at Options is they'll go in for their behavioral physical health. They'll and this is a counselors too can ask them this. Has it been more than a year since your last dental appointment, or when was your last appointment? Do you have any pain in your mouth, and are you experiencing pain? This is something that is asked at that appointment, and also they have a feeder board out front for me, and that was kind of implemented after I was there a year. So that's what I'm saying, like over time, you know, everybody else gets on board too, and they want to see dental successful too, because we've had so many success stories with patients.
And I think I'll just add, going back to the barriers, you don't have to go back to that slide, but you know, one of the barriers that we've experienced, of course, was COVID. That was a huge barrier for us seeing these members, but also I would say workforce. I know that's kind of a bad word right now because we have such a shortage of hygienists and dentists. it's really affected the ability of Kelly to be in the clinics more than she has been in the past. And, you know, the CCOs, because we're held to the metrics, the incentive measures and the measures that we have to complete every year, there have been times where Kelly has had to leave the clinic or give up days there because she needs to go into the schools and help out doing preventive visits there and sealants. So it's it can be challenging sometimes trying, because you want to do, you know, you want to have her, I would have her there 5 days a week if we could, but because the measures are there, we have to take her out. And well, I don't have to. Capital has to redirect her into the schools to do those services. So it can be a little challenging sometimes.
And challenges too, even with the medical assistants too, the changeover I have seen, and you have to, you know, represent yourself. And that's a key, that's huge, because the turnover, they don't understand that. What I think Brittany and them were talking about that, and looks about how, I mean, they have to buy into this, and I sometimes I'm like, no, they're leaving, and then I gotta re-educate again what I'm doing. So but you know, I've met a lot of great people through the way with this. You have to remain a positive attitude with that. But that is a huge barrier right now. It's the change at the front desk, even at the other clinic I'm at too. It's like, oh my gosh, we've gone through like 4 different front office people in the last 6 months. But I just kind of, you know, keep my cheerfulness up and educate them and what we're doing, and you know, seems to be working. But it can be a challenge at clinics for sure.
And I think, you know, Kelly has multiple conversations with providers and medical assistants there and educates them, just like she educates the patients that she sees on the importance of oral health and getting to the dentist. Next slide.
So phase 1 is the oral health assessments, fluoride varnish, the silver dynamine fluoride, sealants, nutritional counseling, talking about tobacco cessation, oral health instructions, and the risk assessments, of course, and then the coordination of care. You know, we've kind of touched on all that stuff, but kind of the basic stuff. But all these things are huge. They're building relations, especially in the behavioral health. It's building relationships. And it's making, because a lot of them come in very fearful. So I am the go-to person, and I have a couple of my stories. We'll talk about how I've met some people at clinics as well to just kind of help them get over that fear. Next slide, please.
So phase 2, we've been trying to do, I think we might be back on track now for that. But again, because of COVID and other issues that take Kelly away from the clinic, it's been a little challenging. But you know, eventually we would love to have to get Kelly an intraoral camera and move into these services here at Options and Grants Pass Clinic. So like I said, COVID really set us back on that, but I think we're on our way to potentially start moving into phase 2 now. Next slide.
So these are, we just touched on a couple success stories. This is one of my patients in the first year that I was there. He was a gentleman that had no dental insurance, and he did have multiple abscesses on the lower teeth. He was not feeling well. He did live like in a trailer and didn't have, you know, his oral health wasn't as well, probably just so many circumstances behind all that. But I ended up getting an appointment with the Medical Teams International bus. We set up an appointment. He did miss that appointment. I said, well, how can we get you there? So I did agree to meet him. I did call him a half hour ahead. I said, hey, are we going over? Yes, I'm getting ready. So I said, okay, I'll meet you there, because they set up in a church parking lot. And I thought it was good for me to go over and you know, show my face as well, because then they're like, hey, you know, this is someone that's been sitting as patients. I go over there with him. I'm able to check out the Medical Teams International bus and everything. So he was able to get those teeth extracted that day. I did see him. It was like about a month later. He was feeling so much better because one of his problems was he was very tired and he had overslept for his appointment because of probably not feeling well with the dental abscess. And it was the partnership with the nurse practitioner being able to give him antibiotics. We did have to do a couple of rounds, but it was so successful. And I have seen him since. It's been really great.
Next slide.
This is another one of my patients that he had 17 decayed teeth. He was very nervous about brushing his teeth due to the fluoride. So instead of being like, oh no, you have to use fluoride toothpaste, I just thought, okay, we gotta figure out something different. So I did go get him like 3 or 4 different natural toothpaste on my own. I said, come see me next week. I'll be back and I'll have something for you. So I was able to give him that several different types of toothpaste to use. I just want him at this point just to brush. He does live in a group home. So he came back, he started brushing, but then I saw him another visit and he was very depressed, had his head hung down low. He had walked quite a ways to come see me that day. He said he was feeling like he was suicidal and that he wanted to kill himself. And I was like, whoa. So I have to sometimes, because I'm not a counselor and stuff like that, I always step back and say, I am a hygienist and I am a mom too, and your life is valued. So we did talk through that a little bit. I had to put on a different hat. I was able to connect him with the, I said, just give me a few minutes. I was able to connect him with a behavioral health specialist. He was able to get immediate counseling that day. And then he did come back and see me and he was doing so much better. It's amazing how you don't realize the different circumstances you're going to be in, but it is very rewarding to know that you have helped with this person in so many different ways.
Next slide. I think we'll just keep going with the next slide. I know we're getting short on time. If you could go to the next slide. So this is a picture, and we did get permission for this. This is a picture of the reader board that sits at options for people to see that Kelly is there. And this is actually a picture of the man that was suicidal, that Kelly was able to connect with services. And we share this story because that's really what this is about, is the fact that Kelly was in this clinic providing dental services and had a patient and a person come in there that was suicidal. And we believe, beyond a shadow of doubt, that she was very instrumental in caring for this man, and she was able to do a warm handoff right away. So that was really great for us. Next slide. And just want to tell about her.
Yeah, so this is one of my patients that I've had this past year. She had moved from New York. She had some really bad impacted third molars, and then she's
wisdom teeth.
Yes, the wisdom teeth, but just like her gums and other teeth are not in such great shape. She had told me about where's her living conditions. She was in all she could afford to is move into this trailer that ex-drugs users had used, so there was no plumbing in it, and some of the old shag carpet she's had to be sleeping on, but she didn't have the ability to brush her teeth in there. So she had to go outside, use the public bathroom that's connected to this trailer park and go in there. It took me back a little bit, you hear these stories. So I did connect her with All Care. We got her a member, or how do you say that? Care coordination person to help her. And I have since seen her several times. She has been able to get her a better living condition. She is so much happier. She is actually one of my patients that's in transition. She's so excited to show me she had changed her name. Her name is, maybe I shouldn't say that on here, but she has changed her name. And, but she wanted to show me her driver's license that she got this all taken care of. I have really, sometimes I have to step back because I want to help them too much. But I was able to, I got a free water pick for something. I'm like, here, I gave her something. I know we have to be careful with some of those things, but she really needed it with her gum tissue and everything. But it's okay. I have boundaries. We leave it at that. But I'm so excited for her. She loves it here in Oregon. She's starting to thrive. So we've done a great job with All Care and the state with these people.
And I think that's why we're highlighting this, is it's really important that you have a good relationship with your CCO so you can use that care coordination piece to help people. Next slide. A couple of things we'll just touch on really quick. We want to continue this model. We know there's other folks that are doing this model. It's really exciting. Hopefully dental therapists, we do have them. We have a couple of dental therapists in Oregon, and they can start practicing. We really would like to see if we can integrate the EHR. That is a huge barrier unless you have Epic, which has a dental module. So it's really tough to be able to access information when you don't have an integrated system. And next slide. I believe that's it. Okay. And we can take a couple of questions if you'd like, Lisa.
Wow. Just shout out, Kelly. You're doing some phenomenal work. You have a question already teed up in the chat, and I'll let others start to think of their questions. From Paul Walter, have you attempted to perform oral health evaluations for diabetics through asynchronous visits in cooperation with a DCO or other dentist?
I mean, I do have my diabetic patients that come through. I have quite a few actually through options, and we do get them connected with their DCO so they can, I think is what you're asking, so they can capture that metric as well too. Am I answering that?
Is that, I don't know, Paul, if you want to elaborate on your question a little bit.
Yes, yeah, Paul Walter here. Yeah, I'm referring more to the ability to do the evaluation and then send maybe some images to a licensed dentist who then signs off on that oral evaluation.
So that's in phase 2, because when I see them, obviously it doesn't, they have to see a dentist to get that metric for that. But that's in phase 2, is be able to send, because you have to have the full complete exam done by the dentist. So that's part of the coordination care, getting their appointment set up for them, scheduling all that, and getting them into the dental office.
Yeah, that's what I was gonna say, Paul. You know, because we don't have the intraoral camera and we're not into phase 2 yet. Basically, I mean, Kelly, if she knows someone has diabetes and she is in their mouth and sees, you know, oh my gosh, there's definitely a problem here. Let's get this person into their dentist, no matter if it's a Capital Dental person or an Advantage Dental member or someone with no insurance, which she tries to redirect to maybe one of our FQHCs. She will get that referral in, and we will get that member in right away.
And I think once it goes to teledentistry, it would be I'm pretty sure it's a metric at that point too. Yes.
I hope that potentially answered your question, Paul.
That does, and it's very helpful. Thank you.
So really, Kelly's acting like a care coordinator to make sure there's some kind of closed loop referral system to whomever clinic, whatever payer and or non-payer, you know, connecting into the FQHC to make sure the individual.
And I'll just add really quick that you know, our dental partners have been just really on board with the Unitas platform. And so they are able to use the Unitas platform to send and receive referrals, which has been wonderful. It's been wonderful. So I appreciate all the partnership with using Unitas too.
So good to have not just even the partnership, but also the technology to support the means of communication to make that actually a little easier on Kelly to, close loop referral. Great.
And oh, I didn't
yes,
know if
Laura.
you had any more questions, Lisa. And
Not yet.
I'll just end with, we try and just show people that this is something that can be done. It's like I said earlier, it's not something that happens overnight, but if you can get some team members that you think might be on board with this, that's a good place to start. And, eventually, I mean, it's like we say, and we said earlier, the mouth is part of the body, and we really should have a system where that's recognized, whether that be the provider looking in the mouth and, like Alexa's team talked about earlier, the pediatric providers going into seeing the kids in their offices, or it's Kelly seeing kids at Grants Pass Clinic or in this behavioral health setting. I mean, this, Kelly and I have talked about this to some partners nationally, and they're just amazed that we're doing the fluoride varnish work in the pediatric clinic, like Alexa's team talked about earlier, or we have this hygienist embedded in a mental health clinic, a behavioral health clinic that also has a physical health clinic. And so she's able, if someone needs antibiotics, she's able to do that warm handoff again and get those people taken care of. So again, it's the from womb to tomb saying that we really kind of go back to, because we just want to make sure that oral health is recognized, the importance of it is recognized, and shout out to the state of Oregon and all the oral health providers and health professionals that are doing this work, because it has to be a collaborative effort. The CCOs need the partnership with the DCOs to do this work. So shout out to Oregon for all the good work that we're doing.
That was the one thing when we traveled this last year, we learned more like, wow, we're way more progressive than a lot of states. So we had a lot of people coming up to us, talk to me about this. I even had, and was in Texas, the one where the gal's like, talk to me about the silver diamine fluoride. And I think, oh my gosh, we are so lucky we get to utilize this in Oregon. So it's been very eye-opening with that. Mm-hmm. So I'm pretty excited that we're a progressive state like that, and then being able to collaborate the CCOs and the DCOs. Very fortunate.
And the behavioral health providers.
Yes.
Any questions, hand raising, cameras, chatting, chat strings?
And I'll just add, if we're all open to emails, questions. If you have them, feel free to email us. If you have any questions at all, Alexa and Brittany and Kelly and I work together. And it has to be a collaborative effort with whatever partner you're working with. And I appreciate all the work again that Alexa and Brittany do. And we've learned a ton from them. And we also appreciate the opportunity to be here today and share all about oral health and the work that we're doing as organizations.
I agree with Jeannie. Thank you to all the presenters, Alexa, Brittany, Kelly, Laura. I think it's almost as a PCP, I understand the need to have healthy mouth and the self-esteem issues that come with it. And I think even, again, that really resonates with what you, Kelly, and Laura have said, especially in the behavioral health setting. Actually, I do a little bit of care coordination for members of my family in the exact space that you were mentioning, Kelly. So I was like, nope, I actually have done that equally, and for a member that had some abscess and mental health, and I was like, no, that's exactly and to see that joy and the smile on the face of the just something simple as I too can smile with the teeth that I have and the joy that brings the space that makes them feel good. And so it's what we do. I think you have all brought very different ways to do oral health integration, but what to me, it's kind of like, I see like 4 Ps. You need the partnership. Obviously you need some payment, which you just provided a whole bunch of different ways payment can happen with a bunch of different codes, right? So you need partnership, you need payment, and you need some platforms. So whether that's integrated EHR, sometimes easy, sometimes not, whether that's integrated referral systems, but you do need some platform ways to make that, and you need some process or workflows. So what you just all receive, CCOs, is some toolkits and or some very clear methods that it can be done. So thank you all for showing and doing the work, which is great. So Jeannie, unless you have any other last closing thoughts, or Laura, because you are our oral health chair, I am so thankful for you all bringing this forth. And I'm sure I'll be reading your toolkit at the very least. If there's any other questions, thank you, Paul, for the nice comments. I did happen to drop the evaluation link as well in the chat. So if you could please use that. We as a actual transformation center who helps put these on, as well as the chair group, do like to look at the actual evaluations to kind of know where we need to go in these learning sessions. And we will share it with the actual speakers as well. So any questions? Otherwise, we will reconvene at 1 o'clock for the quality performance improvement session, and everyone can have a lovely lunch and be safe, because I hear snow might come for some of us in Oregon. Well, that's what I've been told by the Lauras.
Awesome. Thanks, Lisa. And thank you everyone again.
Thank you.
Thank you.
Lisa, I can hear you.
Hi, Laura.
How are you?
Good. I'm still processing. You know, I'm still like, you know how hard it is to cook lunch, eat lunch, take care of your animal in 30 minutes?
Oh, I even ran down and got my husband a Valentine's Day card.
Wow. Well, first off, that's very considerate of you. Second off, I haven't gotten that far. I should probably do that after, what year are we in? I don't even know how many years I've been married. I should probably find the Valentine's Day card or go get one, because that's tomorrow, isn't it?
Yes, yes, it is. Why? So in all transparency, when we got to the question part of Laura's presentation where people were asking questions, that's when I ran. I put you guys on my cell phone so I can listen to you in the car. As I drove down there real quick, ran in, got my card, ran out, and was back here in plenty of time.
Well, I'm going to give you a solid. The Lauras are in the same organization. So Laura Matola happens to know all about Laura McKean's body of work, because they are in the same organization.
Yes.
But, you know, everyone else should be, you know, learning about Laura McKean's body of work.
And I listened to the whole thing until we got to the part where it's time to ask questions.
Okay. Okay.
Wow. I wouldn't run out on your presentation.
Your presentation was done. You were fielding questions, young lady.
Okay. Okay.
Well, everyone can see how this afternoon is going to go.
Well, you did a great job too. I'm really proud of you guys and the work you're doing.
Thank you.
That was really, really cool, actually, because I do actually have everyone, you know, I'm sometimes like, why I do this work. I have a very large family, and I actually it is a true story. I actually did do what Kelly is doing for an individual family member, and seeing his face I mean, first you have to get them out of crisis, right? You have to get them out of their mental health crisis first. And I was like, we'll get to your teeth after I get you out of the actual hospital. Let's deal with the crisis first. But he's like, what about my teeth? And I'm like, just give me a minute, man. Right? But because for him, he really wanted his teeth taken care of. And I was just like, let's I don't know, let's deal with the skin cancer first. But I'll get to your teeth. So when we got to his teeth, he was just as happy as a little clam, because he was just so proud. Because if you think about a person's teeth, I mean, it's visual, right? And so I totally, resonate a couple with Kelly's stories in that oral health integration learning collaborative. Those aren't aware of what we're talking about, because at least my brother, when I got his teeth taken care of, he was so proud and so happy, because we got his teeth cleaned, we got the abscess pulled out and all that stuff. And every time he gets back from that dentist or the EFTA, he's just so happy. And I was just like, okie doke, check. And I never even thought about it from assistance perspective, because obviously I'm just taking care of the brother. But you are doing some great work there, Laura and Kelly, which does need to get spread.
Thank you.
Okay, it's 1:05. So Laura Matola, I'm switching now to my other QHOC chair. You ready to get going?
Yes.
Okay, welcome to the Quality Performance Improvement afternoon session of QHOC now. It is Monday the 13th. We are going to be starting at 1:05 for those that don't know. There is a OHA wellness policy, which starts meetings 5 minutes after the hour, if it's anything over an hour meeting. And so for some of the staff that do join meetings that are OHA staff, starting after the 5 minutes after the hours is part of our OHA wellness policy. So that's why it starts at 1:05 now. Just a couple of tips for meeting participation. Please keep your line on mute when you're not talking. Please no hold music. Y'all have been doing really good at that. So nice job on that. I do like classical music, just not on this meeting. Please use the raise hand function or the chat function. And when you are speaking, if you could use a few reminders to use your name and your organization you're from. So for those that don't remember, I am Lisa Bowie, your Quality Improvement Director here at OHA, and your trusted facilitator for this meeting. Your QHOC chair is
Laura Matola.
She's waving. Laura Matola. Let's go ahead and go to the next slide. I have a few announcements. We covered a couple in the morning, but for the afternoon announcements. The next few afternoon sessions that Laura and I have teed up. Mental Health Access Statewide PIP. What we thought we'd do is, y'all have been working through that. Obviously you went through validation and last July, you got those results back. You also turned in recently your quarterlies. We thought we'd work with the behavioral health directors and the quality directors on this. So Laura, Jeremy Kohler, who's the behavioral health director at HealthShare, but also your QHOC behavioral health chair. We talked about doing a combined, combined. And so the behavioral health directors and quality directors will come together at the 1 to 3 session in March to do a kind of a peer learning. We will talk between Laura, Jeremy, and I kind of what the breakouts will look like, but that will be in March. And in April, the statewide PIP external quality review validation technical assistance webinar will happen through HSAG. So that will be from 1 to 3. Again, that's not specific to any of the statewide PIP. So we have the SUD statewide PIP and we have the integration statewide PIP. So that's the mental health access and the IET. What HSAG will do, will go through the validation technical assistance. So they'll go over the schedule, they'll go over obviously the forms, all those technical things. So that technical assistance webinar will be at the QPI session in April. To just a reminder for TQS, you have the opportunity to submit one project. That one project deadline is, I believe, this Wednesday. So please, if you are going to submit the one project, do so by Wednesday. And you can submit it to the Transformation Center email address. Another notation is OHA is doing a, well, actually it's the state, but OHA is part of that, in which we are doing email migration. I have now been migrated. In other words, that means my email domain address has changed. So at some point, they will cut off my old email address. Obviously, right now, things are being forwarded, but at some point, it will not be. So please make notation of my new email address domain. There is another update that I didn't get onto the email or onto the slide. The question around the SUD statewide PIP, the IET initiation, engagement, and treatment of alcohol and other drug measure. I reported last month about checking in with the analysts about when we would know about baseline data, and well, one, who the analyst is, and two, when we'll know about getting baseline data and like when and how you'll get that. So I do have the analyst name. So as a reminder, your mental health access statewide PIP analyst is Jason Slot. The IET analyst name is Drew Doctor. I will email this all out to you in the follow-up email. Because of claims lags, both of these measures are through claims lags. Your mental health access statewide PIP data will come through the regular way that you've been getting it, again, through the CCO dashboard portal. You get that the third Wednesday or the last Wednesday of the month. That's when you'll get the mental health access statewide PIP data at the last Wednesday of April. As far as the IET baseline data, I am still working with Drew and the analyst team on that one because it's around the HEDIS specifications and the implementation of those HEDIS specifications within OHA. We have to obviously wait for claims lag, but then we also need to, I need to check in on something around HEDIS specifications implementation. So the answer is, I don't know yet. I do know who the analyst is, which is Drew, and they'll work in conjunction with the incentive measure team, who is Frank Wu and team. So I will follow up with both those teams and get back to you all on the anticipated date of when you'll have the baseline data. I'm hopeful it'd be around that same time, which is that last Wednesday of the month, but I don't have confirmation of the IET baseline data. Any questions about any of the announcements?
Lisa, just a reminder that the registration for the CMS Quality Conference opened up at the end of January, so they can go ahead and register for that.
Oh, yes. I think I sent a couple different emails about that. So yes.
You did.
Good job, Laura. Anything else or questions? I threw a lot at you. I'll be sending up a follow-up email with a couple of items from the HERC, and then I'll let you know about the two analyst contacts about the statewide PIP data in case there's any follow-up questions. Okay, next slide. Oh, let's go back a slide then. We're not ready for that one yet. Okay, so Laura and I were talking about, obviously we already have March and April teed up, and what we were talking about for this month. When we were thinking through what to do for February, we were saying, well, you got TQS submissions due in a month. That well, CCO should probably, I don't know, be prepping those and or collating, your projects across that document. And when TQS was created in 2018, and then the iterations of TQS since then, we've done what we call those peer learnings, where you bring a project forward. And actually we just did one of those, where you bring a project forward and you learn about each other's project. But we haven't done for a while how you approach TQS as CCOs. And what that means is, like, how do you staff it? Sometimes actually, and I get these questions, and sometimes they just naturally surface as well. But how do you staff it? How do you, this questions come up, how do you close out a project? When do you close out a project? When you design your TQS projects, what does it mean? What do you do for your subdelegates? And so we thought this would be a time to do that. It could also be a time of, hey, I have this one project and I don't know what to do with it, which is what we usually bring and surface during TQS office hours. So this could be any and all that time. We are going to do this during, hang on, my mouse is dead again. My home office station is not exactly working out. We were going to do this during breakout sessions. So we are going to do a small group. I'm going to put the prompts that Laura and I just kind of reviewed and set up. These prompts are not necessarily like you have to follow them. They can be you can take the conversation wherever you want. But we thought we'd come up with a couple options for people to consider. I'm going to drop the prompt now that my mouse is working again into the chat stream. Well, I thought it was working. There it is. So the prompts that we kind of came up with, which are things that we either get, and we have the TQS leads here. Carrie, you're on the line as well. Is that a,
yes.
Is that a,
yes, indeed.
Hi, Carrie. Carrie's one of the OHA TQS leads. Our other TQS lead from the Transformation Center is out unexpectedly. So you have Carrie and myself here. And so when we come back as a larger group, we are able to kind of field any questions that might surface. So we can kind of do a report out and you'll be like, hey, TQS leads, we don't understand this about TQS. And then we'll hopefully maybe be able to give some real-time guidance. Let me see why. Okay. Well, let me see if my computer really does not like me right now. What you all should know is I cannot set up a home office. I can do many things, but IT is not one of them. Hang on, I'm gonna try and see if I can get Laura. Can you see if you can put the prompts in the chat stream?
Yep, the 3 from this morning and the one I added.
Yeah, the one you added, I wrote, does your TQS project include subcontractors in the areas like ...
Okay.
That's your question, but my computer decided to not. It's done. It's done with QHOC, everyone. Here, hopefully you can. It won't let me do the chat. It won't let me do anything right now with Zoom. So I'm gonna let you try. Let me see if I can even do breakout rooms. I think I can do breakout rooms.
Okay,
Oh,
I got them in there for you.
Oh, good. Great. I can't chat, just so everyone knows. If you try and chat me, it's not happening. I might have to leave the meeting and join back in. I will initiate the breakout room. So the prompts are, how do you approach closing out a project? That question we've received consistently. Another question we've received is, how do you approach implementation of TQS in your organization? So a question we've gotten consistently is kind of staffing, data, resourcing. So is TQS live in your quality department? Does it live in your population management department? How are you doing intersectionality with equity? So that's another common question we get. Another question is, how are you approaching it? We're thinking about the new waiver policies. Are you thinking about changing out projects? So that's a question that's come in. And then to Laura's question of, how are your projects tied in with your subdelegates, or are they? I mean, let's not assume they are. So are they? Okay, so let's see if I can make breakout rooms happen now. Let's do some math. I think we're going to do about 6 breakout rooms. Or 5. I'm going to do 5. And you're just going to automatically be assigned. So everybody make a friend. Okay, here you go. The Wizard of Oz, because I really do feel like it's probably like the Wizard of Oz coming over the voice in the broadcast, but the broadcast written message usually doesn't get seen. So they added this new feature where I can just broadcast my voice, which is creepy, but it works apparently oh so well. Okay, let's hope that someone took notes and you all can do a report out. How do you want to do this, Laura? You're on mute.
I was grabbing that water. Should we go by room?
That sounds good, except for one of the rooms I merged with another room. So I'm going to skip number 4, but let's start on room number 1. Room 1. Any volunteers?
I think that was my group. This is Amanda from Advanced Health. I had Pacific Source, IHN, Health Share in my group. And I was able to, we had a really robust discussion, and we actually added a couple of questions towards the end there. But, we talked that the approach to closing out projects depends on the project itself and whether there's excitement or momentum in the interventions, or whether there's been progress on the performance of the metrics outlined in the project. And so that was pretty much a consensus. And the implementation of TQS inside the organization, majority was housed in the quality arena, and with lots of collaborators and some coordinators to bring it all together. Definitely a wide organization approach to management of the TQS. And then we talked about, changing projects in anticipation of the waiver policies. And there was kind of a mixed response to alignment with the 1115 waiver. Ultimately, though, for those CCOs who didn't have like a one person makes the decisions on the projects and then reaches out to the collaborators, it was more so out of their wheelhouse to align those things. And the anticipation was that the subject matter experts who were brought to the table on the project would have more information on how it aligns with the waiver. And then we talked about subcontractors, and there are many of us in my group who engaged NEMT providers, dental or contractors, dental and SPMI population subcontractors in their TQS work. So that was pretty wide. And I think those were the original questions. Anybody feel free to share if I left something out.
What? Lots of notes. Sorry, I was trying to capture some of those. Thank you. Anything to add from team one? Amanda had you guys covered. Team two.
Well, this is Lance from Umpqua Health, and I guess it goes to show the luck of the draw when it comes to getting put into a breakout room. The breakout room I was in was comprised mostly of persons who work on the fringe of TQS, PIP, and other quality things, and not so much directly on those projects themselves. So our discussion was a little bit different in that, when it came to the 4 questions, the general consensus was, as far as question 1, how do we address the wind down? It was basically a bunch of quality professionals saying, we follow the spec and this is the process. So it wasn't quite so much about, the elements of how an individual project would be dealt with, but more just the specifics of following the spec for the wind down. Because, we've seen the TQS docs, we know how to submit a request for a change in project. So just kind of stuck with that, kind of a dig on my team. We didn't have Juliana or Courtney with us to, provide some greater wisdom on that to the group that I was in. But as far as question, I think question 2 was how are there any considerations for the 1115 waiver policy, et cetera? And the general consensus there was that when it came to projects, be looking forward at what we're expecting to come down the pike from the 1115 waiver and the changes that is eliciting, across the spectrum with all of the different things, and just being aware of how that's going to impact us. So when we are looking at our TQS and other projects, to see how we can align that better with what we're anticipating to come down, so that we're not creating additional work. Instead, we're wrapping the work in that is already being done, if that makes sense. And then when it came to the question of subcontractors, I'm forgetting a question here, but when it came to the question of subcontractors, because of the nature of the individuals in group 2, there wasn't really a lot of discussion there because we were all, kind of outside on the fringe of that. What was the question I missed? Apparently I didn't take notes on 4 questions.
How do you approach the implementation of TQS in your organization? Staffing, data, resourcing.
That one. Yes. So naturally, the most expansive one we actually talked about. I forgot to take notes because I was so involved in the conversation. But with that, it's the addressing of need, looking at the different strata of care and seeing, like, especially with right now, it being kind of a good opportunity to start switching some of the TQS out for possibly newer ones with considerations for the 1115, looking at making sure that you're pulling in all of the correct people from your collective group, be that your quality manager, your statistics people, whoever you happen to have available on all of the different teams, your care management, making sure you have at least one point of contact for any of the areas that your theory might impact, and then having a nice robust discussion with those persons to build out the project concept before trying to enact something. So that way you don't get, halfway through the process of building your TQS and realize that you completely forgot to address equity, something like that. So just, making sure that there's a robust discussion between all parties involved in the process of building up that TQS, and that it's assessing and addressing a need that actually exists and not just an idea. Yeah, I think that was about it. And I showed off another picture of my dog. There you go.
Oh.
Okay. We're just gonna take a moment. Thanks, Lance, for the summary and the pictures, and you're getting some claps. What's the dog's name, Lance?
The dog's name is Lechka, He's about 12 years old, a little geriatric, half German Shepherd. The other half is Malamute and Husky. And he is the world's greatest office assistant. When I'm just too stressed or irritated, I will just reach down, bury my face in his fur, and all my problems go away.
We could all use an office assistant like that.
Exactly.
That works. Thank you so much. Anything else to add from Team 2? Sherry's giving you a shout out. And Team 3.
Okay, so Team 3, you're going to have to help me if nobody's going to speak up to make sure I get everything right. So we talked about closing out projects. We had 2 in our group that were looking at closing out their projects. One is on the fence on whether they want to close it out or not, but it was due to stagnation, that there's just the project hasn't really been moving forward that well. A lot of it has to do with workforce issues, and we know that's an issue across the board. And the other one was looking at closing theirs out as well, just because it's been a 3-year project. It's coming to its natural conclusion, and so that was the 2 that we're looking at possibly closing out their projects. We did talk about how we approach the implementation across the TQS across the company or across your CCO. We have some great CCO leaders that were on the call that, you know, that they are new to the projects or they're new to their roles. And so they're working with their partners within their organizations to get familiar and build up and have those reports uplifted to them. I know we talked about how depending on what the TQS project is, there's various different leads for those projects, and a lot do the subject matter. Hold on. Cynthia, you have an echo coming through. Maybe that was just me. And so the subject matter experts will do a lot of the groundwork and get things moving and rolling, and then it gets rolled up through the company to higher up within each organization. We briefly talked about changing our projects out in anticipation of the new waiver. And I think that we thought it was very thoughtful, but I don't think anybody was at that point where they were really looking at doing that yet. And then we had one dental plan that was actually in our group, and they did talk about the work that they are doing with their PIP, but also we talked about how how we do integrate our subcontractors into some of our projects. Did I miss anything?
No one's saying differently, so I'm gonna take that as a yes. You're good.
Thank you.
Okay, we're skipping group 4 because I believe we merged them in. Is that a fair statement, Tyler? And I'm putting you on the spot there, Tyler.
Tyler came and joined us in 3.
Hi. Yeah, this is Tyler. Yeah, so for group 4, I did join. I was lucky enough to join in with the previous group, so I feel like I align with them.
Okay. Just wanted to make sure we didn't have anything else to add on the singular. Let's go to group 5.
Okay, that is me. Can you hear me? Thanks. We've had so many technical issues with sound today in this meeting for some reason, but glad you can hear me. So we were group 5, and I am from Umpqua, and we had representatives from Umpqua as well as ESCCO and Trillium. So for the first one, I think really similar to some of what the other groups are saying as far as how we approach closing out projects, there was discussion around, adopting of the project interventions as best practices and workflows across the company. So really kind of having those projects come to, again, a natural ending and implementing a new project. And then also other reasons for closing out projects are shifting some projects to align better with OHA's expectations for specific component requirements. And then also it was mentioned that if there were CCOs working with perhaps partner entities or subcontractors, that sometimes those projects have set deadlines, especially if they're grant funded programs. So that would be another reason for closing out a project and implementing a new one. And then as far as approaching implementation of TQS in each organization, I think it was also kind of similar. Most of it's housed within the quality departments, it sounds like, with kind of a main TQS coordinator or project manager who then works with specific project leads to get updates around the different projects and have them complete the write-ups ideally. And then for the new waiver piece, I think that was also another one where it was, some CCOs have considered it, others maybe haven't, but would like to. I know Juliana from Umpqua also shared that we're looking at incorporating or have factored in incorporating some of the HRSN program requirements into the SUH project due to the new waiver requirements that are coming. So, starting to kind of think about alignment there. And then for the subcontractor question, it does sound like contractors, specifically calling out the DCOs for the oral health integration component, and that they just kind of also clarified that they're the ones that lead the project write-up and all of those pieces, that they work with them on the project elements and gathering updates from them. And I think that's it, but I want to see if anyone else from my group thinks I missed anything. I also know Laura was in our group, which was very exciting because she had taken extensive notes for us. So Laura, did I miss anything?
I'll maybe just bring up, so there are kind of three other big kind of discussion topics, and I won't go into much detail, but maybe topics for future discussion or group discussion. One was how CCOs are addressing the alignment between different deliverables, metrics, PIPs, TQS, or whether they keep them separated. And kind of the conversation seemed like bigger CCOs may be very separate so far. This is probably easier for smaller CCOs, but could have some really important and meaningful impact. Second was approach to real D. It sounds like getting the data and analyzing it has been pretty achievable. And maybe the harder part is figuring out how to, once you see the gap, how to address it, how to change an existing or continuing project, how to change that workflow in addressing those gaps. And then the third, how the CCO addresses bringing the TQS to the quality improvement committee, whether that's all as a big chunk or project by project. And there are some varying approaches. But those were big discussion topics for our group. Great discussion.
Thanks, Laura.
Those are some really good future topics for us to chew on and think about. I don't think there was a group 6. Was there a group 6? I should know that since I created the breakout room, but that was like so an hour ago. Okay. Thank you so much. What the TQS OHA TQS leads will do. Thank you, Laura, for so much for stepping in. On the third leg of this stool. So we have three legs of the stool since TQS has started: transformation, quality, and quality assurance. So quality improvement, quality assurance, and transformation. So thank you, Laura Krieger, for stepping in on that transformation side. The OHA TQS leads will talk and debrief this information. I will also talk to our QHOC chairs, the Laura's and Jeremy, and we'll also see where we can weave in some of these questions. Hang on, Tyler has a question for us. So speaking of TQS, do we have more information on access reporting? I'm going to turn that over to Carrie Williamson in the quality assurance team.
That will be coming very, very soon. In the next few weeks, we're just working on finalizing some alignment with the DSN annual reporting. So we make sure we're not duplicating efforts there. So more on that very soon.
There you go. Hot off the presses of new information. So again, we want to obviously try and have that alignment and make sure it's as useful and moving forward with the quality areas. So we will take hopefully this rich information and think through of how to move TQS forward, but also have it move forward in relevancy and in ways that is helpful. You have teed up some future questions, not even sure where to go with those. I think when you meant how the CCOs address bring the TQS to the quality committee, I'm assuming it means your quality committee, like within your own CCO quality committee. Is that correct? I just want to make sure.
Yes,
I've heard that
that's correct.
question. Okay, because you have so many rich projects. How do you bring that to your committees and or your CACs, your CAP, your QI committees to get their inputs? Is I'm guessing what the question's getting to. So
yeah, and I think the conversation was more on like whole document going and getting approval of the document itself versus actual individual project work.
So is it how to get the TQS approved from a engagement, or how to get the TQS improved from a compliance? There's actually a couple different ways that that question could be asked and discussed. So we're going to put that in both of those conversations, because there's the compliance side of it from the actual what OHA expects, because it's actually in our guidance document. So Laura, we can circle back to that on the FAQ, because Laura's trusty project manager for TQS, because I know there's that part of it. But then there's the engagement part, which is why we even have the question in the guidance document. So I'm gonna figure that out with the TQS leads and circle back, and we'll figure where we'll plug the next conversations about this. Obviously, we're not going to be able to answer this all for your March submission, but I think this is a relevant conversation as we go for the next iterations. Any other good of the order questions on TQS?
Lisa?
Yes, Dan?
I have a curiosity question. Being a newbie to some of this work, because you know, I come into it and we have PIPs, we have MEPs and TQS, and you know, the different, it's helpful to get some historical view of, you know, why the three separate, and then, you know, the intent, because I know it's all about outcomes and picking different projects, but I'm just trying to figure out why it's, you know, three separate, as in PIP, TQS, MEP, you know, and then you can combine some other projects that may align, some that may not. I'm just trying to understand from a new person's perspective some of that historical knowledge.
Yeah. So the MEP, first off, is now in TQS. So those so that's MEP is now fully inclusive into the TQS. So it's not a standalone. And the PIPs themselves are standalone, partly because it's its own CFR, so Code of Federal Regulations. The TQS itself lines up to, it's probably best that I just walk you through the TQS actual, like the we have a what's it called, PowerPoint presentation from the inception of TQS. And when we do the overview general webinar, we've taken out some of the older slides because it's been around since 2018, but we can actually set you up some time if you want to just email me or Laura, and I can walk you through that.
Okay, I can do
that particular slide deck, because it kind of goes over the origins and such, and I can weave in some of the current state, and that's no problem.
Okay, thank you.
Do that.
And Lisa, I know you mentioned other future topics related to TQS. I wanted to add, it would be interesting to hear from other CCOs as far as how TQS is maybe managed isn't the right word, but I'll use it, managed throughout the year. So knowing that it's an annual that doesn't have a progress report anymore, you know, do CCOs have oversight of each project, or do we just get, you know, back together at the end of the year to wrap up? Or how do those, you know, kind of in line with that quality committee conversation, how is that the projects kind of monitored throughout the year?
Exactly, Cassie. That's going to what I would say. There's the compliance side of how you get, quote, you know, approved, you know, for the submission side. Then there's the cycle of that engagement with your CAP quality committees for the living part of the TQS, of the work itself. And so I'll approach that question from all those angles, and then see how and where we plug those kind of conversations back to this group. Not that we're going to be able to, I mean, we could take that one question and peel it out into multiple angles and see where and how we'll address that in this venue when we talk to the Lauras. Okay, well, now we're going to turn it back over to Carrie. Jennifer, if you wouldn't mind pulling up the slide deck for Jennifer's last agenda topic around Exhibit I. Thank you.
Awesome. Thanks, Lisa. And I'm joined today by my colleagues, Summer and Johnny. I'll let them introduce themselves. John Livier, one of our compliance data analysts, is unable to join us today for this conversation. So I'll pause there and let my colleagues introduce themselves.
Can you hear me okay? This is Summer.
Yeah. Hi, Summer.
Okay. Double check it. I'm off mute. I'm Summer Cox, Quality Assurance and Compliance Specialist with the Quality Assurance and CCO Contract Oversight Unit.
Hello, everyone. My name is Jonathan, but everyone just calls me Johnny. I'm one of the compliance data analysts with the Quality Assurance and Oversight Unit.
Awesome. And I'm Carrie Williamson. I'm also a Quality Assurance and Compliance Specialist with the Quality Assurance and CCO Contract Oversight Unit. So we are here this afternoon to talk about Exhibit I, the Grievance and Appeal System report, and log being the main topic for conversation, the updates to that reporting that we've made for 2023. If we can slide forward, that would be awesome. Thank you. Thank you. Okay, so some big changes happened for Q1 2023, and those changes have been released along with an FAQ. We've been getting really great questions from folks in this group, so thank you for sending those. And we may be doing a version 2 of the FAQ. We're getting more great questions. So, but what you will have seen in the updates for Q1 2023 and beyond from the 2022 version of the reporting, we really tried to streamline the reporting tool formatting, trying to make the file size smaller, removing macros and formulas. Again, that streamlining process, really tried to shore up the instructions so they were clear, what we were looking for in particular data elements. I like clear instructions. I think most people like clear instructions. So we tried to make that as clear as possible, especially with those kind of updated and some new reporting elements. One of those new reporting elements, or two of them, introducing the PA ID, the prior authorization ID, and the NOABD ID, that Notice of Adverse Benefit Determination ID. So, we had a lot of discussion about that in previous QHOC meetings. We got some really great feedback on those data elements. So again, thank you for the great feedback on that. So we introduced those so we would be able to track kind of the life cycle, the lifespan of any denials, appeals, tracking it back to the prior authorization. And this is partly connected to House Bill 2517. Summer, correct me if I misspoke on the number of that House Bill there. I feel like I could speak about that House Bill in my sleep almost at this point. So, part of the House Bill requirements were around shoring up our data gathering on prior authorizations. So we began to move in that direction in 2022 with just, please report on your total number of PAs. We're taking it further in 2023, again, with those IDs, so we can track, if there was an NOABD associated with the PA, and then through the appeal, et cetera, et cetera. So, yeah, enhanced. And then we also removed in this latest iteration of the report, there were some duplicative data elements. So we removed the approval or denial column because we already had that outcome column, I believe in the grievance, in the PA tab, excuse me, pardon me. So, we removed that, again, wanting to not have duplication of data in there, streamline as much as possible. So, we're pretty excited about these changes. Again, the great feedback that you all have provided, the very thoughtful questions that you've posed to us that have, sometimes made us kind of go, oh, we really need to think through that more deeply. So thank you. Thank you for helping us get to where we are in this reporting. And some of the questions, were regarding data elements that have been present in the reporting longstanding. So it, felt again like a good time, or reflecting that it was a good time to dig into the grievance and appeal log and grievance and appeal system report as a whole, and see, what was still needed. And so here we are. And with that, I will stop talking, and I'm going to transition it over to Summer to talk through the FAQ document.
Next slide, please. Okay, so since we published the revised grievance and appeal report templates last November, we've received several thoughtful questions, as Carrie mentioned, from CCOs regarding the changes in the reporting in general. So in response, we've made a couple more updates to the report templates and the instructions with some additional clarification. And we've created this FAQ document with a compilation of all the questions we've received and OHA's response. So hopefully that will further assist CCOs as you all prepare the Q1 2023 submissions, which are due this coming May. An announcement on this actually went out this past Friday, February 10th, in the CCO weekly update. And the FAQ document was posted on the CCO contract Forbes webpage. So it is there available for you all to check out. The updated reporting templates and instructions will also be posted this week, and an email announcement will be distributed to all the CCO contacts from our contracts administrator within the next couple of days. Next slide. I think that's all we have for you all today. Do you have questions for us?
It's all clear. Everybody knows it. It's time to dance.
I like dancing time. I'm sure
Johnny's
questions
dancing.
will come up as folks review the FAQ please continue to email us your questions. You know, we get together and review them very thoroughly to, you know, provide responses to you. So yeah, great. And Summer just put the email in the chat.
Okay, well, thank you, Summer, Johnny, and Carrie, for giving everyone the update on Exhibit I. The last few updates I had, if you were not back from your breakout room and Cynthia and I were just chatting it up, I let everybody know in the morning announcements, I gave an update about health equity grand rounds. So I did attend IHI, the Institute for Health Improvement. They, I call them the kind of, I don't know, I call it the motherland of quality improvement, you know, the Microsoft, the Google, the people that do quality improvement. So IHI does the national conference every December. So I was able to go this last December. So they had a health equity track. So I did go. I will, Laura, probably should figure out when I can do a presentation about all the lessons learned from that conference. At that conference, they released nationally the initiative, I guess I'll call it initiative. I don't know what they're calling it, but it's known as Rise to Health. So I will present on that. But the American Medical Association, the American Hospital Association, and IHI partnered, and possibly a fourth association, can't remember. But those three, plus maybe a fourth, decided to collaborate on health equity. And so when you bring all medical providers, all hospitals, and IHI, that's pretty big. And they've coined it Rise to Health. And they announced it at IHI. And from that, you'll start to see a lot of different initiatives coming out. One of those initiatives was, I believe it was recently, last week, I believe, the health equity grand rounds. If you're familiar with hospital care, they do grand rounds. And the grand round was on history of racism in healthcare. It was a phenomenal grand round series. 1.5 continuing medical education credits, so 1.5 CME credit for providers. It's free. It's right now posted on the ACGME website. So I put the link on, I think it's free. Yeah, I believe so. I listened to it for free. So I put the link on the QHOC announcements, but I put it up on the morning announcements, not the afternoon announcements. So if you go to the QHOC slide deck, go to the morning announcements, and you'll see the history of racism grand rounds link. You can share that with your providers to sign up for the recording and the 1.5 CME. In the grand round hyperlink, you'll also notice it's a series of health equity webinars that are coming up, or grand rounds. They call them grand. The next one is around leadership in your organization around health equity, what you can do within your organization to lead for health equity. So if you click the grand rounds, you'll see the series that's coming up. I will present, Laura and I will figure out how to, or I'll send it in some information about the stuff that's coming up from Rise to Health. This Rise to Health from IHI, which again, IHI is quality improvement, that's what we're doing. So how you do quality improvement, scale up, process, PDSA, all those things, model for improvement, how you do that with health equity is what IHI is in that space of. Then they also have within the health equity, they have a payer and pharmaceutical pillar. You all are payers. They have a payer pharmaceutical pillar within the IHI Rise to Health. So I will be a conduit to try and get you all this information as IHI puts out information within the health equity space, specific around payers, or not even payers, or just general, even provider related information, so that you can give out, you know, the wonderful, beautiful resources. So look for the one that's on the morning announcements that I shared earlier. Any questions about that? And anything else from the floor? Or it's just dance time. No, it's time for everyone to have a few minutes back in their life. Go get some fresh air before the snow comes. Maybe it won't come.
Thank you, Lisa.
You're welcome. Okay.
Thank you.
Everyone have a good afternoon. I will send a couple follow-up items sometime in the next few days. If you did have notes, go ahead and send them over. I'll collate them. Laura and I will make our way through them and figure out how to get them just to the quality folks. Have a good afternoon.